Rishabh, now we can display the slide, the first slide.
Okay. Okay, ma'am.
Dr. Nida,
Yes.
you would be introducing Dr. Daga.
Hello.
Okay. Yeah. You can start.
Let's start. Okay. Good morning, everyone. I feel privileged to welcome you for the World Conference on COVID and Critical Care. To start with the panel discussion on COVID markers, academic numbers or clinical value. To chair this session, our moderator is Dr. Mridul Kumar Daga from Maulana Azad Medical College, New Delhi. Now I request Dr. Daga to introduce the panelists for this discussion.
Of course, I'm privileged to moderate this session and talk about COVID biomarkers. So we have a very esteemed panel to talk about the COVID biomarkers. And we have Dr. Sheila Mahintra, Chief of Critical Care at Tata Memorial Hospital. We have Dr. Arun Sampath, whom you can see, intensivist. We have Dr. Juhi Chandwani joining from she would tell, I forgot, so I'm sorry for that. We have Dr. Vijay Hada, Associate Professor of Pulmonary Medicine at AIIMS. We have Dr. Yes Javeri, who needs no introduction. And we do have with us can you help me in introducing the speakers? I should have done that homework. So can we start the presentation and then I'll introduce the speakers when we do the panel discussion, please? Pandemic phase, I think it was much needed. So what we are going to talk about is COVID biomarkers. Are these academic numbers or they are clinically significant? And it is very important to know that what are these? These are basically objective measurement and evaluation as an indicator of normal biological and pathological processes or pharmacological response to a therapeutic intervention. So it encompasses all aspects of care. And we know now that COVID-19 is not a localized respiratory infection, but a multi-system disease caused by a diffuse systemic process which involves a complex interplay of immunological, inflammatory, and cognitive cascades. And the genetic and acquired differences in the host immune system further complicate the host repertory, leading to wide heterogeneity in clinical picture and outcome. Let's look into one study which they were trying to look into two different subsets, 136 patients admitted in general ward versus 119 in ICU. They looked at ICU at outcome at 12 weeks, and they found that in the general ward, almost 40% of the patients either had to be shifted to ICU or they died, while in ICU, only 31, that's 23%, had mortality. And what were the predictors of outcome when they looked into it? They found that endothelial activation and chemotaxis is the predominant thing which was seen in patients admitted to the ward, which is the earliest phase of the disease. And that's why you need an enhanced endothelial integration and chemotaxis limitation to limit chemotaxis to improve the outcome. On the other hand, when in ICU, you already have enhanced inflammation, complement system activation, and coagulation, so you need multiple intervention. We all know that once this virus enters the alveoli, what it causes, the break in endothelium, and there's generation of then cytokines, but that's a later phase. Initially, there's the chemotaxis and endothelial disruption, which is causing the problem. And of course, we know IL-6, IL-10, IL-1 alpha. On the other hand, once this progresses further, activation of complement, in addition to these disruption and chemotaxis, then there is angiogenesis, cell-to-cell interaction, bacterial superinfection, and you have high mortality in there. So you found the determination of deleterious marker in two distinct cohorts with different clinical severity and biological insights of the immune response based on the patient's clinical severity. So one size fitting all is not correct. And you have to see that endothelial dysfunction sets in earlier. Then you need to have host-directed treatment strategies. And maybe you use IL-6 inhibitors. We already know that it is a global problem. You have a lot of observational studies about biomarkers. Some of them are less expensive, faster, and easier to do and can predict outcomes. And the common one from some of the studies, like one study which had 32 studies in meta-analysis, common like lymphocyte count, decreased platelet count, elevated CRP, procalcitonin, D-dimer, LDH, liver enzymes were associated with poor outcome. And so you need to see all these to guide your treatment and prognosis. Now, another study where 429 patients studied, 42% had severe disease and rest had non-severe disease. And they looked into very simple markers like WBC, NLR, SGOT, sodium and potassium. And they found they had lymphopenia, thrombocytopenia, C-reactive protein being high, elevated all these markers, all those who had poorer outcomes, as you can see here. All those, they had elevated ALT, they had creatinine elevation, they had D-dimer elevation, they had LDH elevation. So we know that biomarkers may help us in finding early suspicion of disease, confirmation and classification of disease severity, framing hospital admission criteria, ICU admission criteria, rationalizing therapy, assessing response to therapies, predicting outcome, and criteria for discharge. And these are the different biomarkers: hematological, WBC count, neutrophil count, lymphocyte count, T cell and B cell count, NK cell count, biochemical, liver enzymes, CK, LDH, myoglobin, cardiac troponin, albumin, coagulation parameters, PT and D-dimer, inflammatory marker, ESR, CRP, serum ferritin, interleukins, and some new markers like homocysteine, angiotensin, NLR ratio, or angiotensin 17, 19, L-amendine, which are being studied. So, which I already talked about. So what is the temporal course? Within first 7 days, you would find PLC and lymphocyte normal or slightly low. You may have increased LDH, increased liver enzyme, CK, CKMB. 7 to 14 days, TLC and these progressively further fall, reaching nadir in 8 to 9 days. Thrombocytopenia, increased IL-6, IL-10, and the 1RA, IL-1 RA, increasing total leukocyte count, lymphocyte platelet count, and more than 14 days. If you have that, that predicts the recovery. So for diagnosis, you may have markers like leukopenia, lymphopenia, increased high LNR ratio, increased LDH and LIST. For assessing severity, again, lymphocytes, NLR, IL-2R lymphocyte ratio, IL-6, CRP, ferritin, D-dimer, all these would an anti-Pro-B can be used. Response to therapy, you can use CRP or IL-6 decrease. Prognosis, you can think of IL-6, ferritin, LDH, CRP, procalcitonin, lymphocyte count, platelet count, specific cardiobiomarker, and a miscellaneous, which has combination of all these, including albumin. So if the patient has asymptomatic or mild category, no comorbidity, no biomarkers needed. With comorbidity or moderate category, you would do CBC, CRP, creatinine, LFT at admission. If symptoms persist in second week, please repeat these and decide further. If any of these are abnormal at the beginning, what you do is do PT, APTT, INR, serum, D-dimer, ferritin, anti-Pro-B, anti-Trop1, troponin 1. Additionally, you may do an IL-6 and serial lactate. Hospitalized patients, you need to monitor all the CBC and CRP every 48 to 72 hours, but there is no definite role of serum ferritin to monitor the response, except you're thinking that there is secondary HLH. So these are some of the new biomarkers: homocysteine, angiotensin 2, angiotensin 17, 19, L-amendine, which are being studied. And we should also understand that there are distinct informative profiles distinguishing COVID-19 from influenza with limited contribution from cytokine storm. And we must appreciate this, that in patients, in contrast to our assumptions earlier, very few patients, I would say just 7 of the 168 patients with COVID-19 exhibited cytokine profiles indicative of cytokine storm syndrome. And after controlling for multiple factors, including age and sample time point, patients with COVID-19 exhibited lower cytokine levels than patients with influenza. So you must understand that patients with COVID-19 are less inflamed than patients with influenza. To summarize, biomarkers are important and integral part of COVID management. Always correlate clinical condition with biomarkers, not only to prognosticate, but to guide treatment as well. But what is most critical is the judicious use to improve outcomes. Thank you very much for your patient hearing. So, welcome all panelists from all across the globe. It's my pleasure to welcome you all, and extremely grateful for sparing your valuable time. We all know that biomarkers are one of the important component of our COVID management in terms of patient assessment of disease severity, of outcome, of prognostication, and even therapy, what therapy we should go ahead with when we plan some specific therapy. We know that with the trials in June, July published, we became familiar with using small doses of steroid as probably one, ray of hope in these patients, which we did not have in initial first wave for a few months. And then subsequently, a lot of things have come. We have had a lot of publications of a lot of therapies, even biomarkers and therapy use. So to set the ball rolling, I would like to know from Professor Sheila. She is, I think, I need to introduce her. She is Professor of Anesthesiology and our future President of ISCCM. Congratulations. And I see really a bright future for ISCCM, Sheila.
Thank you, sir.
Sheila, so why do you think we do really even need biomarkers? You know, I mean, I remember older days, we would see patients clinically bedside, we will start therapy and then we'll do some investigation, wait for them. But so why do we think we need some biomarkers in this patients upfront or maybe?
Right. Thank you, sir. I think this is a very relevant question. So we've always had lab medicine supporting clinical medicine, of course, and like any other condition, when we had COVID-19, we really didn't know much about this disease, and we started to do a lot of biomarkers, and you were expecting, the so-called cytokine storm that we were thinking about. So we did a whole gamut of biomarkers trying to understand the disease. But over time, what has happened, and as you have already alluded to in your presentation, we've had lots of studies looking at various biomarkers, helping us risk stratify. And most recently in BMJ, we've got the meta-analysis of 35 studies, which have shown that, yes, there is an association of increased mortality when you have leukopenia, when you have thrombocytopenia, and elevated biomarkers for inflammatory biomarkers, and also the other biomarkers like LDH and ferritin, and also metabolic markers. But what we have not been able to really identify is, which one should we really exactly target and at what value. This does give us some idea that, yes, it's associated with increased mortality. So what I would say is that definitely what we want to know as an intensivist is that which of these patients are going to come to ICU. So if you can use these biomarkers to risk stratify that this patient is likely to go to ICU, especially in the context of a pandemic where you need to, do a lot of rationalization of your resources. And within the ICU, what I need to know is that which patients are going to worsen or have, go onto the ventilator, and also which patients are going to have a worst outcome. So this is where I would look at the role of biomarkers. And we've try to understand this. And, there's a very interesting study. So I think just looking at all the biomarkers at all the stages in COVID, what we've understood is really, it depends on the phase of the disease. And I saw a very interesting study recently published in the Lancet, and this was from Van de Beek, Professor Van de Beek. And what he did is he did something very interesting where he looked at two categories of patients. He looked at patients in the ward, and he looked at patients in the ICU. And in the ward, the outcome was looking at ICU admission. And in the ICU, it was looking at mortality. And they did a whole panel of 64 biomarkers. And what they found was that those biomarkers in the ward patients, which were with the elevation of endothelial activation, those ones actually predicted admission to ICU. And within the ICU, it was those that were involved with, activation of the coagulation complement system or, inflammatory activation. So where I look at it is, though we don't know which one and what level, definitely if we target these biomarkers at different phases of the disease, this is where they might be, useful.
I fully agree. I think I also have alluded to that study in my presentation. Thank you, Dr. Sheila, Professor Sheila, for this. So, and do you think, is this thought appropriate that to know that in non-COVID viral pneumonia, like we had H1N1 epidemic, or we had earlier, we do keep on having some now, the viruses which are causing problem. So do you think in non-COVID viral pneumonia, there was never an emphasis on so many biomarkers and different stages? So what is your thought on that? I mean, we know that, yeah, there is something different in pathophysiology, but upfront, if you want to say for, say, a minute or so.
This is actually something that has really baffled me, because we've always had pneumonias and ARDS, and we've done all these inflammatory markers, we've done these biomarkers, IL-6, IL-1, IL-10, and the whole range of it, but we've never targeted our therapy to this. In fact, if you see in COVID-19 compared to other viral infections that we've had, there isn't a predominant cytokine storm as one would have imagined. And even the inflammatory mediators aren't that high as we have seen with other ARDS pneumonias. So
I fully agree. I fully agree that
yeah.
IL-6 levels are 100, 76.
Yeah.
You see those to be 500 in patients with other.
Exactly. So why are we targeting this? But what is very interesting to see is that I would say the therapies with the studies. If you look at previous pneumonias, we've used steroids, we've tried tocilizumab, we've tried all these therapies, but they've never really proven to be beneficial in these kinds of pneumonias. But this is COVID-19 is one disease where we found a benefit with steroids, as you've seen with the recovery trial and now the COVID steroid too. We tocilizumab, even monoclonal antibodies. And what's interesting is that it is not just a benefit with the therapy, but it is at the phase of the disease. For example, we've seen that monoclonal antibodies work better in out-of-hospital patients, whereas steroids are working better in oxygen-dependent patients. Tocilizumab is working when your CRP levels are high, like you see in recovery. So I would say that in this setting, to identify in which phase of the disease. So you have a predominantly pneumonic phase, and then you have this hyperinflammation. So it will kind of help you identify where you are with your disease and sort of guide your therapy as to, are you really responding to therapy? So this is where I feel there is a difference. But I don't think it is because there is a cytokine storm. In fact, the values are much lower, as you
right. I fully agree. And any other panelists want to say something, but let's go with the questions first. And thank you so much, but please do not leave. We require your input. Can I ask Dr. Yash now? Yash, Yash, can you hear me? Dr. Yash Javeri?
Got disconnected.
Yeah. Oh, he's not there. So I can ask someone else then. Dr. Chariot, can we come to you?
So you asked me the same question?
No. The questions for you are, what do you think specifically of CRP?
Oh, okay.
As a single marker to guide your therapy, to prognosticate. Can it be one of the only two biomarkers you would like to do to look into the outcome and all that? Can it be one of the leader in that?
Yeah, practically in our country, when we look at the disease, as Shia said, the disease has at least 2 or 3 phases. The first phase is viral phase. The first week or first 5 days, the patient have viral infection and viremia. And the second phase is the cytokine storm, as all you know. The patient have a lot of inflammation from the disease, characteristics of the disease, and causing severe ARDS or something. And the late phase, the stage of complication like secondary infection or thromboembolism or something. So what we practically use, I believe that as I'm a critical care medicine, so we take care of kind of serious patient, and we focus on the phase from the patient who have regular symptomatic patient with pneumonia who are turning to have ARDS or serious disease, and we need something to figure out that the patient is really in that state. So I believe that CRP is a good one, and we practically use CRP in my country. So when the patient.
Do you think you would require, in addition to CRP, in moderate disease, moderate to severe or moderate disease, how frequently you would require that, and do you think you would use one more in case you find that the CRP levels are going high? you want to know something more and you want to use another biomarker to?
I tell you, in the theory, people may test CRP at the beginning when the patient have pneumonia or mild pneumonia, and follow up when the patient condition get worse. And according to the recovery tocilizumab or something trial, the trial enter point is CRP level more than 75. So we use that the level 75
Right.
to be the cut point to
Right.
judge that the patient are in cytokine storm, and we start to use tocilizumab on that
Right.
point, right?
So that's a very good point you are making. You don't need IL-6 to start tocilizumab. Even at that level of CRP, you would. I mean, you don't have to wait
Yeah.
for that report. And at that level of CRP, and if you find you are in the right phase, when it's too late, a patient is already on ventilator, you would find that tocilizumab may not be of much help.
When the
So you
patient
use
is on
that.
ventilator, it's too late. I think
Yes,
the patient is turning from the oxygen cannula to high flow or something.
Right.
We may need CRP test
Exactly.
to figure out. And
Right.
Thailand underwent 3 phases of
Thank you.
of COVID, and on
I
the
just
first
wanted
phase,
to
use
know.
IL-6.
Okay, I just wanted to know about NL ratio. You think this is also very critical?
Oh, we don't use NL ratio at all.
You don't use? Okay.
I don't use it
All
at all.
right. All right, no issue.
Saga, if I may just add one line about
Yeah.
this question. So I just want to say in the Indian context, I know there are a lot of hospitals doing a whole battery of biomarkers, but if there was one biomarker I had to choose, like Professor just mentioned, it would be the CRP, because
Exactly.
this is very simple to do, easily available widely, and studies like your, the recovery trial have already, I mean, have used.
Already proved.
I think if you had to do one, CRP would be the one I would choose.
I know. Yeah, Yash.
Hello, sir. Good evening.
Welcome. I know you are a very busy person. Thank you
No,
very
no,
much.
not at all, sir. There was some
Yash
internet
doesn't
issue.
need any introduction. We see him in, leading as ISCCM in years to come. And right now you are based in a hot city in news for no good
Wrong reasons.
I
For
know.
wrong reasons.
But anyhow, so yes, what do you think? I mean, before you order biomarkers, I mean, or you think in terms of, we have already talked about some of them. I mean, if you want to order some specific biomarkers, not the CBC and neutrophilic lymphocyte ratio, or even for that matter, CRP, some other specific biomarkers, what would be your choice? How would you decide? I mean,
when we order a biomarker, we should know what is the pre-test probability of it, if it is positive or negative. If we get a quantitative report, it is always better.
Right.
We have to put biomarker in the right context. The major part is clinical context. Biomarker is a corroborative evidence, if I say, and biomarker is yet not a fully grown investigation. The evidence on biomarker is still not that clear that we call it an investigation. That is why probably the evidence is not yet clear in diagnostics. If we talk about COVID, we have to understand the phase of disease before we order a biomarker. What was happening? People were at home, no oxygen, day 2 or day 3 of illness, and they were having whole battery of tests. And if those tests were normal, the biomarkers, TNF, IL-6, everything was being done. If those biomarkers were normal, they were little laid back, and once they were getting sick, they were having this false belief that their biomarkers were normal. So they were not getting due attention. So we have to understand what phase of disease we have to do biomarker, as Sheila Madam already told. CRP is the biomarker which will be of utility in most of the phases of illness. Now, how were we using these biomarkers? We were using CRP in almost all patients, all fresh patients, and
you were talking of all hospitalized patients?
All hospitalized patients. All hospitalized patients.
Okay.
And patients who were coming to emergency or critical care as little serious patients. We were doing CRP in all of those patients. If the patient has passed day 7 or day 8 of illness and had moderate severity, we would offer them TNF or IL-6 at times. Initially, we were doing D-dimer for all the patients, but as we learned more about COVID, we stopped doing D-dimer and start giving maximum prophylaxis based on their body habitus and the clinical condition.
Okay, so we will,
Procalcitonin, we
yeah,
were
we will
also
come
doing,
to that.
sir.
We will come to that also. Yeah, you are right, absolutely. I mean, you don't have to, and one of the most misused biomarker was D-dimer. Misused in every front. We will talk about that.
Sir.
And yes, please stay with us. There'll be,
Yes, sir.
I mean, you will add to certain things and move that. Can I go to Dr. Fayaz now? And yeah, good evening.
Good evening.
So what do you think? We already talked about a little bit about timing of biomarkers. And so in a patient admitted with you with moderate to severe disease, and he's on high flow oxygen or on all that, how frequently you would repeat biomarkers, and which one would you repeat?
I would say that they are important consideration when we discuss the utility of biomarkers in management of COVID-19 patient. And I think throughout 1 year and a half, we all were bombarded by COVID-19 patient. We learned quite a lot how to use and utilize biomarkers. While in the beginning of the pandemic, we were in a chaos, we started to use lots of biomarkers. And by the mid of the pandemic, we became more specific in what we send and how often we send it. Many of the hospitals, including in my country, we run out of reagents to do these tests at one given point of time. So while initially we were doing every 48 hours, every 72 hours, repeating the panel of C-reactive protein, repeating D-dimers, looking into procalcitonin level, looking into interleukin levels. These were into the category of sick patient in ICU setting requiring high flow oxygen. We started to become more judges later on in the repeating of these tests. And as my colleague said here, it's all depend on which phase the patient is at.
Right.
And it is a collaborative biomarkers, a bundle of biomarkers that you look at rather than individual. Many hospitals in the periphery in my country would like some of the biomarkers that were in the available in the tertiary care centers.
Right.
So when we put our own national guidelines, from the beginning, we considered that we should be practical, and especially that many of these biomarkers, it was not clear how to utilize them in the beginning.
Right.
So in our national guidelines, we requested them to repeat things that are available everywhere. So a CBC will particularly note on lymphopenia was an important consideration.
Right.
Calcium was another important biomarker. We could look at it as a marker that is available in all hospitals. And also in our setting, we have shown that it was also associated with decrease, with increased risk of transferring to ICU. So it was hypocalcemia significantly was associated with high rates of ICU transfer. Addition to that, there were other things like LDH in the beginning, but then this LDH dropped and D-dimer as well. Those are the majority that we were requesting them to repeat them every 72 hours. Later on, when we revised our national guidelines, these things became less important, to be honest with you.
Okay. Thank you so much for giving good insight into this. And just off the record, just wanted to say that even hypermagnesemia is being also, a lot of studies, they found that a lot of these patients had hypermagnesemia. So,
absolutely.
they had. So, coming to
also into vitamin D, and we looked into albumin as well, all these markers. And singly, none of them, presented as the key biomarker, but multiple of them were helpful to some extent.
Dr. Hada, please. I know there's a difficult question for you. The question for you is, do we really need to some specificity and sensitivity of these biomarkers we order? Or, I mean, as Yash has already said, yes, we need to know. And in the COVID setting. And second, the most important thing is, what is, do we look into the response? What is happening to the biomarkers in different heterogeneous population we have, On one side, we have, although now the data is available from one of the meta-analysis is covering all ICUs all across the world. And so is that genetic factor important or heterogeneity in these biomarkers? What has been your experience in COVID? You've been handling COVID patients.
So, sir, thank you for the question. And I think this is very, very pertinent question. Although if we see the literature, there will be lots of study, and Dr. Sheila have already pointed out that there was a meta-analysis recently published, which have shown more than 60 biomarkers. So if we see all those studies and we compare two groups, so differences are statistically significant, means they are in statistical terms, they are significant. But if you see, there will be lots of overlap between one group versus other, meaning thereby their sensitivity and specificity is very, very low. Okay, so unless we find a marker which have very good sensitivity or specificity in terms of if I say exact number, so anything which is more than 80% sensitive or specific is considered as a little bit acceptable kind of marker. But most of the studies which we have seen the biomarkers, they are not even touching the 80. They are mostly 50-60%. So they are just moderate or just fair kind of association. So I will say that till date, there are so many biomarkers, and most of them are non-specific, although they are very sensitive. For example, every one of us is agreeing that CRP is one marker which can be done in almost all the patients, and it can be very useful in prediction of various outcomes. But if you see, CRP is very, very non-specific. Even slightest of inflammation, slightest of infection, slightest of injury can lead to CRP rise. So these things we need to keep in mind whenever we are selecting that which biomarker we need to take in consideration while we are taking any kind of clinical decision.
And even host response, we have observed that, I mean, anecdotally or a lot of times that some individuals had, we were talking of hypoxia, we were talking about patients on SpO2s of 60s and 70s for 3 days, not agreeing for ventilation and then recovering. There were a lot of things happening. CRP is being moderately elevated I know a few patients, and they did very well, and the CRP is going even high, and they did not really require any, great ICU care, and they recovered. So we don't know. There is host response, heterogeneity. Those questions still remain unanswered in seto population. But yes, meta-analysis with few thousand patients, looking into that was Dr. Sheila was referring to, and I alluded in my presentation also, has shown us that yes, you can choose some biomarkers in which we will be talking about.
Sir, that's the point I was trying to tell, that
right.
In a given patient, it is very, very difficult. But
Right.
yes, there are few biomarkers. The second part of your question, you were telling that there is lots of heterogeneity. So in science, we have read that phenotype is described as genotype.
Yeah.
And
Exactly.
in COVID also, people have looked into this concept, and I came across very interesting study where they have conducted a study in 23 countries, and India was also part of that. So
Right.
they tried to see the polymorphism of the interleukin-6 gene,
Right.
and they found that there are few polymorphism or genotype of the interleukin-6. They change the susceptibility as well as the severity of disease. Even the outcomes are also changing.
Yes,
So
sir.
yes, genotype is very, very important thing. And similarly, there are few data which suggest that linkage with HLA. For example, HLA A23.01, it makes more susceptible. The people who are carrying this
Right.
one, they are more susceptible for development of COVID. Similarly, there are polymorphism in the ACE gene, ACE2
Right.
gene.
That is
Similarly, interleukin-6 as well as interleukin-6 receptors. So there is lots of things happening in the body, and we know that one body is not similar to other one. So genotype plays very, very important role, and that may probably partially explain this.
right.
Why
You are
CRP
right.
high is like that.
right now we are only looking into genotypes of different variants of COVID virus. I know we need to look into that as well. Yeah, thank you. Now coming to,
Sir, I just want to add one thing here, that when you ask which biomarker is more specific and which we should do, I would say that what I have seen that we don't know till now when the patient get infected, in which line he will go, whether he will go to hypercoagulability type, whether the cytokine will lead to more of inflammation. We need a biomarker which can tell us as early as in which lineage the patient is going, so that we can give a specific targeted therapy to them.
Exactly. Yeah, Dr. Juhi. So interleukins, IL-6 inhibitors, tocilizumab, became one of the severe and one of the most sought after drug after steroids, So what are your thoughts about interleukins? Partly we have touched about it, but I think I want to know from you. What do you thought about should we be doing IL-6 levels at all in patients now with the evidence, whatever the evidence is? And if we do only IL-6, or we need to look into some other interleukins also? And what has been your experience?
So thank you for the question, sir. So see, we really are very confused with this disease, and the trajectory of the disease is something we try to learn every day, and we come to know new things almost every day. Now, as an intensivist, we just don't need to manage the patient in the ICU. We need to see how we can prevent them from coming into the ICU. So when you see at the outreach level that before these patients reach the ICU, when their oxygen levels are increasing, and that is the time we need to understand what exactly is happening. As my colleague just now said, whether it is inflammatory, whether it is hypercoagulability, whether it's like embolic issue, what exactly is happening. So we are totally lost at that stage, and we try to target everything all together. Now, at this stage, in the first week, we all know it's a viral replication phase. At the end of 8 days, when things start turning around in a bad way, like, in the way towards ICU, that is the time when we really need something to guide us. CRP does help. Of course, it's more than one reading of CRP. It is the trend of CRP which will really guide us. And since it is available in most of the hospitals, it is very useful for us, and it can be replicated very easily. You can get that test very easily. But in settings where we have the facility, I think interleukin does help to some extent. And once you know the levels, once you are able to get it, then obviously, since we have the targeted therapy for the interleukin, like if our IL-6 level is high, then surely we will be using an IL-6 blocker, like our tocilizumab or whichever drug is available in our respective hospitals. So because there have been studies which have shown mortality benefit, and then there have been controversial studies in Lancet which have shown that these studies were probably not conducted in the way that, they're not really validated studies. So at the minute, since we are lost and we see our patients crashing on day 8 to day 10 to day 14 also, and that is the time, since we have some things available with us like IL-6 blocker, if I was there, I would definitely use it.
You are absolutely right. Absolutely right. I just wanted to add one line that yes, that's the time period when you need to, and if you have available, you should use it. And why make them devoid of that beneficial therapy at that point of time?
And since I don't have anything else, and going on ventilator is going to be the end of the road most of the times in 50-60% of the patients. So if I can prevent them from going to that stage, I would use it. Now,
so do you think you need more interleukins also, or just IL-6 is good enough?
Well, now we have some options like, we have interleukin 1 as well, and we have an interleukin 1 blocker. Now, we don't know. Now, these drugs have been available in the market for a long time, and they have been used for other conditions. And the interleukin levels that we are seeing in COVID is much less compared to other conditions. But still, the way patients progress, as we just now said, we just have to use something to reduce that inflammatory response. Definitely, hyperinflammation is one way of deterioration in these patients. And by controlling that, we might be controlling the other coagulation pathway also, which is also triggered by the inflammation. So probably targeting inflammation may not be a bad option by using either IL-6 inhibitor or IL-1 inhibitor. It is the timing which is important, and the availability of the drug in your setup.
Would you like to repeat it at all once found?
Well, I don't think repeating
IL-6.
is going, no, not at all, because once the receptor is blocked, then the levels are not really going to add much value to your management.
Yeah, Dr. Sampath. Yeah, I can.
The levels will remain high because the receptor
Exactly.
is blocked.
Yeah.
exactly.
Absolutely. That's why it's
Can
no
I add,
value.
sir?
Yeah, Dr. Sampath, you've been waiting for a long. Sorry for that. Yeah. So, what do you think about the cardiac biomarkers? When is the time for them? And we have had series of those. Troponins and anti-pro-BNP and other things like that. So, what do you think is the right group of patients? When do we do it? And its utility in COVID, disease COVID.
Yeah, thanks for your question, sir. So if you take among the cardiac biomarkers, the troponin I and the pro-BNP both have a prognostic value. But however, it is actually misused in the first wave of COVID. Majority of the ICU setups were prescribing to a lot of cardiac drugs based on this positive elevation of troponin I and pro-BNP. We also did in the first wave. Later on, we learned that this is just a marker of myocardial injury, which can happen in COVID. Just it is no significance. Just it can be elevated without any underlying significant cardiac disease or with a significant left ventricular dysfunction. So it is just an indicator of ongoing myocardial injury. So to be frank, that this can have only a prognostic value. Means if it is elevated, especially in a patient with a significant hypoxia, or the patient is in ARDS, so the elevated either the troponin or the pro-BNP gives a prognostication that the patient can have a higher mortality. It has been published in American Journal of Cardiology also. But later on in the second wave, when we have the learning curve, we found that I can make it in 4 scenarios. So the first scenario is if there is an incidental elevation of troponin I or a pro-BNP without any significant evidence of an underlying cardiac disease such as a coronary artery disease, like a normal ECG, normal echo, then just we tend to ignore it. There is no value at all. No need to think about that. The scenario two is, suppose if the patient is also having a suspicion of a concurrent coronary artery disease. For example, if the patient has a ECG changes or the echo is having a regional wall motion abnormality, particularly to a vascular territory, if the troponin I is elevated, then we need to think about a concurrent CAD in the same COVID patients. Suppose if the scenario is the patient is having a disproportionate breathlessness, disproportionate hypoxia to the radiology, and we are suspecting why this radiological findings is not matching with the clinical severity of the breathlessness or the hypoxia. If the patient has a global hypokinesia in echo but not confirming to a particular territory, or the ECG changes is not significant enough to say a coronary artery disease, and in this situation, if the troponin I or pro-BNP is elevated, it may suggest a myocarditis, which is very common in COVID, especially in a severe inflammatory phase of COVID. So it can be a myocarditis. The fourth scenario which we have seen is, suppose if the patient is having hypoxia, but the troponin I is elevated, but normal echo, but with the PAH, we are also thinking about it could be a concurrent pulmonary thromboembolism. So there could be a different scenarios. We can use the same biomarkers in a different clinical evaluation. Overall, if you see, the cardiac biomarkers have no particular role, should not be misused. That I can.
That's right. That's the bottom line. I think that's the point straight away that we did not to do, because everyone was getting this test done. Thank you so much for elucidating it so nicely. I think we left for 2, 3, 4 minutes only. Sandeep has not come. So Sandeep, one of the most misused biomarker, D-dimer. Because I know of that patients were on anticoagulants for months. Even at home, they were not given only anticoagulants, but even antiplatelets with just elevated D-dimer, no symptoms, no hypoxia. So what do you think is the D-dimer's role in what situations in COVID?
Sir,
Sandeep, you have 2 minutes. I'm sorry, not more
I'll
than
take
2
2
minutes.
minutes only. Just I'm giving. Various guidelines, WHO, NIH guidelines, they have clearly mentioned that there is no role of monitoring D-dimer in non-hospitalized patient, that is milder patient. However, if the patient is hospitalized, then it do have a role in moderate to severe category and critical patients. It should be done at the baseline, and then in moderate cases, it should be repeated after 48 hours, and in moderate cases after 72 hours, and in critical to severe cases after 48 hours. And it should also be done in all those cases who have underlying hypercoagulable states like antiphospholipid syndromes or valvular heart disease. It should be done in all these things. So basically, D-dimer is to we want to know whether the patient is going into hypercoagulable state, and second is we want to monitor our anticoagulation therapy. That's why we do D-dimer. However, the evidence suggests there is till now all the data has been reviewed, and there is no evidence. I would say there is insufficient evidence to recommend either for or against the use of D-dimer monitoring for making decisions in the management of COVID or hypercoagulation states. So D-dimer cannot be used for making decisions to alter the anticoagulation therapy. And it has been said that all those who have been hospitalized, they should be given thromboprophylaxis irrespective, regardless of the D-dimer levels.
Exactly.
And there have been various trials like ATT, ACC, ACT4 and REMAP trial, where they have shown that the therapeutic levels of anticoagulation is a futile thing, rather than the patient should be given only prophylactic doses of anticoagulation in COVID only, who are not suffering from other hypercoagulable states. So in nutshell, D-dimer should be done at baseline, should not be done in the non-hospitalized patient, should only be done in the hospitalized patient for just monitoring purposes, not for making decision whether anticoagulation is to be given or not.
I think you put in right perspective, Ira. There are many unanswered questions as yet, but I think paucity of time doesn't permit me now. He's pointing to me that it is 40 minutes, the time limit. Thank you very much, all of us. Just to summarize, I would say that yes, use your biomarkers very judiciously. Minimum use only in hospitalized patients. When taking or thinking of taking decision to initiate a new therapy, you can use it sometimes like interleukin or sometimes even, but I've not touched upon ferritin, which was another one which was been done so frequently, but probably that is not much needed. It can only point to a secondary HLH syndrome, sepsis following COVID and all that. Ferritin can be very high. So in nutshell, I think we still are learning, but you've learned a lot. And thank you very much for all the panelists for giving such a wonderful exposition to the topic. I hope it will help all of us. Thank you very much.
Thank you, sir.
Thank you so
Thank
much.
you, sir. Thank you very much. Thank you. Thank you.
Much.
Thank you.
So if there are any, are you left with any? Are left with any time for any questions or anything? Any questions coming? I don't see any questions or anything. Was there any time for some questions? No.
So we do have time for the questions. I mean, you can put across to any of the speakers if you want. We do have time in hand.
Yeah. So, you know, most of the things we have answered, all the panelists. I'm sorry I made a fox pause in not introducing you all. But when we know Dr. Joy is from Muscat and Dr. Harriet from Thailand, Dr. Karyal from Israel. So I have one or two small questions just to supplement what you talked about. And one of the important things which we did not touch upon that is lymphopenia. Just simple lymphopenia guiding the therapy and prognosticating. So anyone wants to say something on that or NL ratio? Please unmute people if they want to say something. I think they can unmute themselves. Dr. Juhi or Dr. Sampath.
Yeah, good morning, sir. So,
You want to say something about NL ratio or your experience with that or
yeah,
lymphopenia?
yes, sir. So, though it has been mentioned that NL ratio more than 3 is a marker for severity of COVID, but we don't find any particular association between this particular lymphopenia versus the severity of COVID. So it can happen with the, for example, the COVID with the secondary infection also. The particular neutrophilia itself can displace the lymphocyte to the lower level, or the ratio can be skewed to one side. So we don't know exact reason why it has been documented as only lymphopenia as a marker for COVID. So in our center, we are not following that NL ratio. We do
Right.
usually follow the CRP as we were
Right.
already discussed in the panel.
Absolutely. I think Dr. Juhi, if you want to give some input.
Yeah, exactly. I agree with Dr. Yeah, sorry. I agree with Dr. Sampath actually. Lymphopenia is a very general thing. And in fact, in many of the critical ill patients, irrespective of COVID, you do find lymphopenia. So it's not a very specific thing for COVID. So we also actually, I mean, we definitely use it as one of the marker to say that patient is having COVID, but we don't really use the NL ratio to guide us for the therapy as such. It just corroborates.
Yeah, and in fact, one of the meta-analysis done and looking into this, they did find that yes, it does corroborate with the disease diagnosis and disease a little bit in terms of thinking in terms of that maybe they would get secondary infection or they would likely to have that, but unlikely to really say very significantly about that. But other thing I wanted to know was that so that we should tell that very clearly that the most, I mean, crucial or the most important biomarker should be CRP universally.
Yes.
There is no doubt about that for guiding your therapy.
Absolutely.
And rest, all other biomarkers can, case to case basis one can think of, and one can then, decide about the therapy and management. And there is no need to order a battery of 10, 12, 15 of these, or doing only 2 or 3 of these at right time, at right moment is very, very critical. And that window period is between days 7 to 10 and 12. That's the critical window period for one to decide. Anything anyone else wants to add, Dr. Sheila, or anything else they are there, or Dr.
We had nice discussions, sir. I think it's a good learning for us too.
No, you all have contributed. Dr. Sheila, you have anything to say? I know.
Right. I think we had a very lively discussion and everything. Most of the points have been very beautifully brought out by the panelists. And I think the real message here is that, these biomarkers can at best just help guide, but they should not replace your clinical management of the patient. At best, they can guide you. And if at all I had to do one biomarker, which is cheap and easily available, as I mentioned, it would be the CRP. But just basing your therapy solely on the values of biomarkers is not, as we have understood this now, is not the way forward. And we need a better understanding before we can, swear and say that this is the particular biomarker that we have to use the cutoff value. So it should be used in conjunction with our clinical practice.
I fully agree, yes. So the biomarkers are really in terms of what the heading was given. This is a clinical number or academically significant. Yes, we still need to draw some answer for that. But yes, unnecessarily ordering a lot of those would not be a good choice. Please see the patient in totality and take a decision based on that. Thank you everyone for, wonderful exposition. I had a wonderful panel, so knowledgeable and so expert and all that. And I'm sorry for not introducing you properly. And I apologize for that. Thank you very much.
Thank you, sir.
Also, thank you. Thank you very much. Thank you.
Thank you so much.
So,
Thank you so much,
So-
Dr. Daga sir, and our esteemed panelists for a very knowledgeable discussion. Let us start with the first thematic session of the day.
Dr. Nida, you're not audible.
Am I audible now?
Not clearly.
Am I audible now?
Rishabh?
so
Yeah.
Am I audible now?
Yeah. Yes, you are.
Should I start the session?
So the next session is at 13:30.
Yeah. Thank you so much, Daga sir, and our esteemed panelists for the very knowledgeable discussion. Let us start the first thematic session of the day. To chair this session,
sorry, Nida,
yes.
I think Shilpi said that there are still 15 more minutes remaining for the session to start.
Okay.
Shilpi-
Yeah.
Okay, so Shilpi, what time? So you want us to be there for the session live? We are chairing the session.
Yes, ma'am, you would be required live, so you can join
Okay.
in back around 1:15, or maybe you can just stay here on the Zoom link and explore the platform a little more.
Yeah, sure.
And
I'll
yeah.
do that. Yeah. Thank you.
Welcome.
Okay, ma'am.
Rishabh, play the holding slides that I had sent you. Play the holding slides. Rishabh,
हेलो हाँ जी हेलो
लास्ट वाली स्लाइड है ना, वी विल बी लाइव शॉर्टली, वो वाली
ओके
मत प्ले करना.
ओके
हाँ,
बस ये तीन
ये तीन अभी लूप पे प्ले करो, ठीक है?
लूप पे लगाऊं इसे
वाली जो है ना, लास्ट वाली लाइव वाली,
हाँ
that
जी
will stay only if there is any technical
I
glitch
just
or
want to
anything.
check
your
on the
voice is
audible.
not excuse me
और एक काम करो ऋषभ, आप
हाँ
ना
जी
ये डॉक्टर निडा के साथ एक बारी ना इनका टेक चेक कर लो. दूसरे वाले उस पे ले लो कंसोल पे, इनको ये वाला मत टच करो, दूसरी वाली
जी।
विंडो पे लेकर के ना इनको यार इनका थोड़ा सा टेक चेक करवा दो।
नहीं 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 मैम, ऐसे नहीं होगा ना, क्योंकि ये होस्ट ये लाइव जा रही है सारी फीड।
नहीं, बट यू मस्ट बी हैविंग टू सिस्टम्स ना। एक तो आपका
मैम
स्ट्रीमिंग चलता रहेगा, जो
मैम
स्ट्रीमिंग अभी
नहीं,
आपका चल रहा है।
अच्छा आप क्या कर रहे हैं, आप मेरे को बताइए एक बार।
मैं ये बोल रही हूँ कि डॉक्टर निडा का ना एक
हाँ
बारी हाइजीन चेक कर लो। He
हाँ
is having problem with the video also. He was very near to the laptop when she
ओके
had to announce. Okay, one is this thing, and brief her on how to handle the mic, as in like ये जो बार बार वॉइस का इशू आ रहा है ये नहीं आना चाहिए।
मैम आप एक बार अनम्यूट करिए, निदा मैम आप एक बार अनम्यूट करिए। हेलो निदा मैम, प्लीज अनम्यूट योर सेल्फ। मैम आई एम ऑडिबल। हेलो
मैंने अभी किया है।
मैम आई एम ऑडिबल। निदा मैम आई एम ऑडिबल।
Yes, yes. Now you are audible.
हाँ जी मैम बताइए।
I just need to check. Am I audible?
यस मैम यू आर ऑडिबल।
Okay, okay. Because I was not able to listen what you people were saying.
नो 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 नो, नाउ यू आर ऑडिबल
Okay,
ऑन लाइव।
okay, okay.
अनदर
I was
प्रॉब्लम मैम?
no, no. I was just checking. Am I audible or not?
ओके मैम, ओके ओके शिल्पा मैम।
One more thing.
यस
There will be a thematic session first, no?
या thematic section first.
Okay.
We'll play it at 1:30. Okay. Okay.
डॉक्टर निडा, जस्ट वन स्मॉल रिक्वेस्ट। जैसे आप अभी भी इफ यू विल सी ना योरसेल्फ, तो
I'm
आप
not
ना बहुत कैमरा के काफी ज्यादा पास हो।
Okay, okay. I'm
ठीक
not
है?
able to see myself. Basically, sorry.
हाँ, क्यों आपका वो नहीं चल रहा? गुड आफ्टरनून डॉक्टर अशोक।
मैम एक्चुअली
आप ना थोड़ा सा ना डॉक्टर निडा, आप थोड़ा सा पीछे होके बात करो, so that your face is visible to us and to everyone.
Can you please at what times will you start the first session?
1:30.
हाँ,
1:30. Okay, okay.
हाँ,
Is it okay now?
it is little okay. Actually मुझे
Now it's okay.
हाँ, now it is okay.
Now it is
Yes.
okay.
Okay, okay.
आप ना एक बारी तसल्ली से दोबारा से, इफ यू वांट टू प्रैक्टिस नाउ, तो एक बारी क्विकली रन थ्रू कर लो, कोई प्रॉब्लम नहीं है। थोड़ा कंफर्टेबल होके बैठो, ठीक है? नर्वस नहीं होना है।
नहीं, नर्वस नहीं, मैं आई एम वेरी मच कंफर्टेबल। बस वो प्रॉब्लम बीच में ये आ रही थी कि आवाज नहीं आ रही थी, और
आवाज में अभी भी प्रॉब्लम आ रही है,
मैम
ऑडियो में
बेसिकली
अभी भी प्रॉब्लम आ रही
मैम
है।
इट्स फ्रॉम योर नेटवर्क प्रॉब्लम. It's not the problem for our side. Yes.
ये माइक ज्यादा दूर उस वजह से तो नहीं हो रहा है ये?
नहीं मैम, बट वो वॉइस क्रैकेशन तो ऐसा हो सकता है मैम, आप एक काम करें, आप ईयरफोन लगाइए।
ठीक है।
एक्चुअली हेडफोन्स में क्या होता है ना कि इसमें माइक थोड़ा सा दूर होता है।
हाँ, आई एग्री। घनश्याम, ओके, डॉक्टर घनश्याम इज आल्सो हियर।
ठीक है आवाज?
हाँ जी, नाउ इट्स क्लियर।
Who is Nirmal Hospital, Surat?
And I just need to confirm that.
Hello. Hello.
Who is that speaking? Is that you, Rishabh?
This is Dr. Ghanshyam Jagatkar.
It's Ghanshyam, Dr. Ghanshyam.
Oh, good afternoon, Dr. Ghanshyam.
Good afternoon, Shilpi. Are we running late?
No, sir. We are not running late. The session is going to start at 1:30. So we were just doing some tech checks.
No, I think the hall E ka it was 12:40, na? Nahi. The first session was supposed to be
Yes,
at
sir.
12:40.
The first session was supposed to start at 12:40, but it started at 11:40, and it started around 11:50. So now we have got that buffer time with us. We will be starting sharp at 1:30.
Okay, I'll log in then.
No, so you can be here. You can just be here and you can put yourself on mute. And maybe if you want to explore the platform, you can explore the platform from a different window and then join back.
Okay.
Yeah.
Just let me know whether am I audible?
Yes, you are, sir.
So is it okay now? I'll continue with this my iPad.
Okay, I'm keeping the phone here and let me talk to you. Just a minute.
Just show me whether I'm visible also.
Yes, sir, you are visible. You are visible.
Okay, right.
You just need to fix your your camera a little bit. You need to tilt it a little bit.
Just a minute. Just let me know whether am I audible?
Yes, you are.
So is it okay now? I'll continue with this my iPad.
Okay, I'm keeping the phone here. ऋषभ, ये कहाँ से आ रही है आवाजें?
Just show me whether I'm visible also. Yeah, one more PC I started actually.
Oh.
Okay, now I adjust my camera accordingly.
Sure, when you're live, you're not doing that.
No, I'm not going to do that.
Yeah.
Okay, right.
Can you just raise the level of the laptop, or I mean the iPad that you're using a little bit?
Okay.
Just level it up.
Like this?
Yes. It is little better now. You just need to tilt it so that it seems like you're looking in the mirror.
Is it okay?
It is little better.
Okay. Just a minute.
The voice is clear. No issues with the voice.
बाकीच्यांना काय म्हणा तिकडून जायला म्हणा बाकीचे लोक तू दिवशी बसलं तर बॅकग्राऊंड चाललं ना फोन ट्रेवल Hello.
Yes, sir.
Is it okay now?
Yes, sir. This is fine.
Okay. मतलब इसमें तो
क्वेश्चन आंसर जो चाहते हैं ना कुछ फ्रंट रन में आपको इसके कोई नो जॉब कंप्लीट करना है में कुछ कर्सर के फुल स्क्रीन पे नहीं उसमें आवाज चेक करो सर नेम हॉस्पिटल निकले से तो एक बार जॉइन मेरा एक मैंने જોયું મેં હમણાં બી તે ચેક કરતી હતી ત્યાર બેસીને નિર્મલ હોસ્પિટલ મેં જોયું સર અહીંયા ચાર્જર છે કામ કરવાને પહેલા મ્યુટ કરતો
Okay. ऐकू येते का म्हटलं?
Dr. Nida, are you only going to start for the next session? Dr. Nida, you there? Unmute करें.
Hello. Hello, Shilpi.
Hello. Yes.
Yeah, everything is fine.
Yeah, everything is fine, sir.
Everything is okay.
Can we start?
So we
I
will
think
start
so.
in next 2 minutes. Start in next 2 minutes. क्या कहते हैं? Rishabh, you play that slide for thematic session, okay?
Okay, ma'am. Okay, sure.
Dr. Nida, are you there?
Okay. I'll just.
Dr. Nida?
I
All
am Dr.
answers?
Nikalje. I am Dr. Nikalje.
No, sir. I'm not calling
Dr.
for you.
Nikalje. Dr.
I'm-
Nida is another.
Yes, I'm there. Hello?
Yeah, ma'am, please respond.
Please on your
We need
camera.
to start. Please put on your camera.
Okay.
Rishabh, you take the lead now, okay? For the tech checks and hygiene checks, please take the lead.
Okay, ma'am.
Okay, all the best, everyone.
Should I start?
Can we start the session?
Yeah, we are about
after
to
1
start the
minute.
session. So you need to mute yourself, Dr. Anand. Dr. Nida, you need to be a little louder, please. Tilt your
Okay.
camera a little bit. Yeah, better. Good to go.
Should I start?
Rishabh, please pass on the cue.
Let's start with the thematic session of the day. To chair the person, I welcome Dr. Rakesh Sir, Additional Professor, Department of Onco Anesthesiology and Palliative Medicine from AIIMS, New Delhi. Our second chairperson is Dr. W4C2021, Consultant Anesthetist and Intensivist, Royal Hospital, Muscat, Oman. Our third chairperson is Kamal P. Sodhi, Director and Head Critical Care, Deep Hospital, Ludhiana. And our co-chairperson is Harsh Sabra, Director and HOD of Neurocritical Care, and Neuroanesthesia, Medanta. Now I request Dr. Rakesh Garg to introduce the first speaker of the session.
Thank you so much, ma'am. It's a pleasure to start the thematic session one with a very interesting topic. And the speaker is a very prominent intensivist, Dr. Ashok Kumar Singh. He is Director and Academic Course Coordinator at Department of Pulmonary and Critical Care Medicine at Regency Hospital, Kanpur. He is contributing a lot to the society. He is Joint Secretary of ISCCM UP chapter and also Chairman of ISCCM City Branch, Kanpur. He has many academic laurels and contributions to critical care specialists. Without wasting time, I would request Dr. Singh to give his words of wisdom regarding awake sedation in COVID ICU, which is one of the very important topics that we have seen during the management of COVID-19 pandemic. Over to you, sir.
Good afternoon, everyone. At the outset, I would like to thank the organizing committee of W4C conference for this invitation and opportunity. So I'm going to talk about awake sedation in COVID ICU. As we all know that sedation and analgesia is an important pharmacological intervention in management of critically ill patients, especially the patients are on respiratory support or having some neurological problems like anxiety, stress, and agitation. It's a proven fact with active engagement of the patient, family, and interprofessional team, patient-directed, symptom-based comfort management can be achieved with awake sedation. Awake sedation is associated with reduced mechanical ventilation and ICU stay and may reduce mortality as well. The limitations of awake sedation, it cannot be applied to the very severe grade of the disease patients because they need very high level of ventilative supports, like in the severe ARDS patients, and that patients we need some degree of relaxation and deep sedations. COVID patients are a little bit different as compared to the other patients when they are admitted into the intensive care units. And most of the patients are conscious but having a significant hypoxia. Respiratory reserve is very poor. Most of the patients are on the respiratory support that may be in form of oxygen therapy, HFNC, non-invasive ventilation or invasive ventilation. Most of the patients, they have complete distortion of sleep architecture and there is no definite therapy is available to treat them. Most of the patients, they have long stay in ICU or HDU. So because of these problems, they have extreme anxiety and that leads to the development of increased endogenous catecholamine activity, increased oxygen consumption, tachycardia, tachypnea, hypercoagulability, and hypermetabolism and immunosuppression as well. Anxiety and agitation is very high due to disease phobia and strict isolation from the family members and concern about the high mortality in COVID-19. Awake sedation is the solution for relieving the anxiety and safety in this group of the patients. The advantage of awake sedations that provide patient comfort and ensure patient safety while decreasing the stress response. However, over-sedations occur frequently even with the small sedation and is associated with the longer time of mechanical ventilation and higher probability of developing brain dysfunction. The various drugs are available and we are using day and nights in intensive care unit, but the most common two group of the drugs, one is sedative medications and second is analgesic sedations. And most common molecules which we are practicing, one is the propofol, second is the dextromethorphan, and third is benzodiazepine. Although sometimes clonidine, ketamines, and volatile anesthetics can be used for the same purpose in a particular patients. Propofol is an anesthetics and a GABA agonist, has a proven utility as a sedating agent in ICU due to its rapid onset and the short duration of actions, typically given in the bolus and then continuous infusion. The volume of the distribution is large with a short distribution half-life. Propofol side effects include hypotension and myocardial depression, respiratory depressions, and hypertriglyceridemia is the limiting factor for the propofol infusion. The second molecules which we used very regularly, that is dextromethorphan, and an alpha-2 receptor agonist, opiate-sparing effect. Site of action is presynaptic neuron in the locus ceruleus and the spinal cord. It causes sedation, analgesia without significant respiratory depression. This is the most important advantage of this drug. This is given in the bolus and then infusion for the longer periods. The increased incidence of bradycardia and hypotension is reported in most of the patients, and this is the limiting factor of this drug. Coming to the benzodiazepines, the old drugs and well-trusted drugs, midazolam, lorazepam, diazepam are the most common drugs which we use. They are GABA agonist. The commonest side effect of these drugs is basically many patients, they develop post-extubation psychosis and cause respiratory depression. That's why these drugs are not a drug of choice in patients with COVID who are having very poor respiratory reserve. Now coming to the second group of the drug, that is analgesic sedation, the two most common molecules, that is fentanyls or remifentanil. Fentanyl is a synthetic opiate with a rapid onset of action that occurs within 5 to 15 minutes and a short duration of action, 30 to 60 minutes. The drug is easily titratable as a continuous infusion second to its half-life. Loading dose is given 25 to 100 micrograms followed by infusion of 25 to 250 micrograms per hour. It has a large volume distribution. Therefore, a significant drug accumulations occurs with the prolonged infusion. This is the limitation, and that produces a complication and difficulty in weaning the patients who are on the long term of fentanyl infusions. So this is a preferred drug in a hemodynamically unstable patients or those with the renal insufficiency. This is the advantage of these drugs. The various clinical trials, the various drugs were compared head to head, and it has been found that the dextromethorphan was compared with the benzodiazepine group. It has been proven fact that and demonstrated in this study that the patients sedated with the dextromethorphan have the lower probability of developing delirium as compared to benzodiazepines. So non-benzodiazepine sedatives, either propofol or dextromethorphan, may be a preferred option for wake sedation over benzodiazepines to improve clinical outcome in mechanically ventilated patients, especially in adult ICU. So because many patients of COVID also having associated sepsis, even in that condition, the dextromethorphan is far better as compared to the benzodiazepine. And it is proven fact in this study that dextromethorphan has more degree of brain dysfunction and mechanical ventilations and were less likely to die than those with the received lorazepam-based sedation regimen. So these results were more pronounced in septic patients than in the non-septic patients. Again, the sedation is also needed sometimes in non-invasive ventilations, and dextromethorphan is a good molecules that can be used in non-invasive ventilations, ventilated patients, but bradycardia and hypotension is the limiting factors. This is a meta-analysis which is published in Journal of the Chest in January 2021. Now, how to monitor the awake sedation in the COVID patient, because this point is very, very important. So over-sedation is very risky in COVID patients because of the poor respiratory reserve and high oxygen demand. These patients need strict observation and monitoring. So safety measures and balanced sedations needed and need very strict observations. Now, how to do it? The various sedation scales are available, which we are practicing, but the most common one is Richmond agitation sedation scale, in which we keep the patients most of the times the 0 scale to -2. So take home message from my presentation, there are wide variation in sedation practice and optimal sedation strategy are still lacking. COVID-19 patients are different and need strict monitoring due to low safety margin. Conscious sedation is the right option for relieving anxiety and stress in this group of the patient. Dextromethorphan may be preferred option for this group of the patients. Even conscious sedation in COVID patients need strict monitoring and observation because the patient can deteriorate very fast. Over sedation should be avoided as much as possible. Thank you very much.
Thank you so much, sir, for a wonderful talk. Now I request Dr. Juhi ma'am to introduce the second speaker of the session.
Sorry, Nida. The speaker details are given.
Yes.
Okay. Good morning, everyone. Let's welcome the second speaker for the session, Dr. Ghanshyam Jagatkar. He's a Director, Critical Care for Medicover Hospitals, Hyderabad. He's a National Executive Committee member, ISCCM, and a co-chairperson for Critical Care 2020. Dr. Jagatkar would be speaking on autologous bone marrow stem cell therapy in COVID-19. Welcome, Dr. Ghanshyam Jagatkar.
Hello, everybody. At the outset, let me congratulate the organizing team for a phenomenal effort in organizing this fantastic conference, and also thank them for allowing me to be a part of this show. What I am going to speak to you is a very, very novel intervention that we tried out at the peak of the second wave during May and June, when the COVID cases were coming in huge number. We looked at the role of autologous bone marrow stem cell therapy in the management of severe COVID-19 disease. We have all understood the pathophysiology of COVID, and the current hallmark of COVID-19 related ARDS seems to be the cytokine storm, the virus-induced trigger causing the release of acute inflammatory cytokines like interleukin-2, interleukin-6, 7, MCP1, etc., results in the extensive lung damage leading to the ARDS, and this seems to be the major factor influencing the outcomes of patients who are admitted with severe COVID-19 disease. And if you look at the therapeutic options that have been tried, the 4 pillars, if I have to say, have centered around the use of antivirals. Immunomodulation has played a major role. We have tried different kinds of drugs to modulate the cytokine storm or the hyperimmune response, which was the cause of major mortality. And the steroids seems to be the major player, and most of the data suggesting that steroids are the agents of choice as far as the immunomodulation is concerned. We have also tried anticoagulation, understanding the fact that COVID-19 is a hypercoagulable state, and obviously patients with respiratory disease need oxygen support in various ways. However, what we have also understood was that despite using these 4 pillars and a lot of other novel therapies, the mortality was still very, very high. And that's where the idea or the thought that we need to explore newer therapies was being investigated across the world, including our own country. Now, when you look at the rationale for the use of mesenchymal stem cells, mesenchymal stem cells, as far as their role in the management of diseases or medical conditions is not new, and they have been in practice for a long time. Now, a lot of data is there which clearly suggests that mesenchymal stem cells are fairly safe to use in clinical conditions. And when you give mesenchymal stem cells through the intravenous route, especially in a condition like COVID, a significant number of these cells lodge within the pulmonary vascular bed, which is the major site of damage, or which is a major site of pathology as far as COVID-19 is concerned. Now, when you look at the mechanism of action, we know that mesenchymal stem cells or the stem cells for that matter have the ability to modify and influence almost all the cell types of both the innate as well as the adaptive immunity. They have shown to influence their proliferation, maturation, and have or kind of move from a Th1, which is a pro-inflammatory response, to a more of a Th2, which is an anti-inflammatory response. And that is the key aspect as far as the use of mesenchymal stem cells in COVID-19 is concerned. As I've told in the previous slide, immune or a hyperimmune response seems to be the major pathophysiological background. Now, apart from this, mesenchymal stem cells have also shown to have a significant benefit with respect to their ability to regenerate. And yes, there has been some data, though the data is not very strong, to suggest that they may have antimicrobial properties as well. Evidence is there in the form of phase 1, phase 2 trials, a lot of preclinical animal data. But again, we are still looking at large numbers. However, we do have a lot of centers where smaller numbers have suggested that use of mesenchymal stem cells can be beneficial in severe COVID-19 disease. Now, this was a trial which came from Germany, where they tried to look at the usage of mesenchymal stem cells in patients who were affected with severe COVID, as defined by a PF ratio of less than 100. Now, the numbers are small. There were about 5 patients in the mesenchymal stem cell group versus 18 patients in the standard of care group. If you look at the severity, 4 out of the 5 patients in the stem cell group were put on ECMO support. At the same time, about 9 of 18 patients in the standard of care group required ECMO support. The dose of the stem cell that was given was 1 million per kg as a 30-minute infusion, and 3 patients were given 2 doses and 2 patients were given 3 doses. Now, if you look at the baseline characteristics and the comorbidities, except for the fact that the mesenchymal stem cell group had probably younger group of patients, with respect to the presence or absence of medical conditions or any other drug histories, it was not very significantly different. Now, similarly, if you look at the various laboratory values in the two groups, again, with respect to the inflammatory markers or the inflammatory mediators, there was not much of difference between either of these groups, except for the fact that the mesenchymal stem cell group, those patients were having a higher degree of temperature, probably indicating that probably they were going to a much more severe response. Now, when you look at the data before and after the therapy with mesenchymal stem cells as compared to the control group, with respect to the leukocytes, neutrophils, there was not much of a difference. But with respect to CRP, there was a consistent decline in the CRP levels after mesenchymal stem cells. Now, this was something which was significant between the stem cell therapy group as compared to the control group. Similarly, the interleukin-6 levels also were on a downward trend in the stem cell therapy group. Now, when you look at the respiratory functions or the lung parameters, the PaO2 by FiO2 or the oxygenation was consistently better or significantly better in the mesenchymal stem cell group from admission to discharge. Their respiratory mechanics or the plateau pressures were significantly lower in the stem cell therapy group as compared to the control group. Similarly, if you look at the compliance in the those group of patients which was given mesenchymal stem cells was significantly better than the control group. Now, if you look at the Murray score, which is nothing but a score which tells you about the severity of the lung injury, they found that the Murray score in the mesenchymal stem cell group from admission to discharge showed a steady decline, or indirectly hinting that the patients in the mesenchymal stem cell group, the severity of the lung injury gradually decreased and the lung got better as compared to the control group. And you look at the final ICU morbidity and mortality, or the total the mortality rate, you found that the ICU mortality in the control group was 55.6% as compared to 20% in the stem cell group. Now, I do agree that the numbers are small, but given the fact that this is novel therapy, and there are a lot of other trials as well which have suggested that stem cells could be a potential therapeutic strategy in the management of severe COVID-19 disease. Now, when you look at a lot of other trials, a lot of other data, though the numbers are small, but people have used stem cells in the management of severe COVID-19 disease. And the overall message that we can take from all the trials is, one, stem cells are safe. They are well tolerable. They seem to be fairly effective. And yes, most of the trials have documented a good immunomodulation effect with the use of stem cells. And this seems to be evolving as an alternative approach where you don't have much of choices in the management of this deadly disease. Now, our own concerns when we thought of using stem cells were one, cost. We found that the cost was exorbitantly high. I mean, getting 2 or 3 doses was roughly costing about 4 to 5 lakhs. We were not sure about what were the ethical and legal implications, especially with respect to from where the stem cells have been stored. Again, what is the authenticity or the concentration of the mesenchymal stem cells in the dose that was provided to us was not very, very clear. The sourcing was always a concern, and the time for procuring, we realized that if we had to place an order or to try to get the stem cells, it was taking us at least 48 to 72 hours, where a crucial amount of time period was lost. And that is where we were trying to look at alternatives, and we thought of using bone marrow. As we all know that bone marrow or the bone marrow stem cells have been used extensively for various medical conditions without many major issues. And apart from having stem cells, the bone marrow cells also have a numerous have a large number of other cellular components, such as the hematopoietic stem cells, the natural killer cells, the antigen presenting cells, the regulatory T cells. And we have also, there's also data which suggests that the bone marrow stem cells can also influence the function of the macrophages, which are key molecules or key cells involved in maintaining homeostasis. And the stem cells have shown to divert or kind of move from a macrophage 1, which is a pro-inflammatory, to a macrophage 2 system, which is a more of an anti-inflammatory system. So we found that bone marrow, probably because of the ease and the availability and the evidence that it has been used in the past, could be a suitable alternative. And that is where we try to look at the use of bone marrow stem cells for the management of severe COVID-19 during the period between May and June, where we tried this intervention in about 25 patients. Now, we looked at the use or the effect of autologous bone marrow stem cells in patients who were RT-PCR proven positive, who all had severe COVID-19. All of them were on high oxygen supports with elevated inflammatory markers and the CT showing moderate to severe CT involvement. All patients were above 18 years, and we only took those patients who were less than 14 days since the onset, because we thought that if the patient had already crossed 14 to or second or third week, probably the benefit may not be as significant. And all the patients or their families were spoken to and discussed, and very clearly told about that the fact that this was an experimental therapy, and only when they gave the consent we went ahead. Now, the exclusion criteria with patients who were more than 65 years, we did not involve them because of the the quality of the bone marrow can go down once you cross 40-45 years of age. We are not sure about what are the cellular components. And those patients who presented with advanced sepsis, septic shock, and who were already in multi-organ dysfunction, we were not sure of what kind of benefit this intervention would get us. And if the patient had any known or suspected malignancy, the patient had abnormal cells on the peripheral smear, those patients were excluded. Also, those patients where either the family or the patient did not give consent to the intervention were excluded. Now, the bone marrow stem cells was combined with the standard of care, and the standard of care included remdesivir, steroids. We use methylprednisolone 1 to 2 milligrams per kg twice a day. Oxygen, depending upon the need and the availability, either high flow nasal cannula, intubation, or NIV, whatever was needed, and anticoagulation. This was standard of care. Along with this, we looked at the use of bone marrow stem cells. The way we took is basically the eligible patients from the posterior superior iliac spine, about 50 to 100 ml was aspirated, and this was collected in the blood collection bag, which was had the anticoagulant, because we found that when we were aspirating, a lot of aspirate was I mean, the clot formation was very, very significant in patients who were severe COVID-19, and this was immediately transfused through the blood transfusion set. Now, one of the concerns that we had was whether this could lead to fat embolism. So before we started this therapy, we did speak to the pathologists and try to examine the slide pre-filter and post-filter, and found that the post-filter, the fat or the fat globules as large molecules was not evident. Now, when you look at the data, there were 25 patients. Among those patients who discharged as well compared to those patients who died, not much of difference with respect to the comorbidities, symptom onset, or the duration of treatment. 16 patients did not require intubation. They were managed with NIV and high flow, but 9 patients required intubation, of which 1 patient went on to ECMO. Now, when they look at the various inflammatory markers before the treatment and after the treatment, we found that the CRP as a means of the inflammatory marker, the CRP levels had a dramatic reduction after the therapy in patients who survived. The LDH also decreased, but this was not very statistically significant. There was not much of change with the D-dimer. And as far as the oxygenation as measured by the pulse oximeter was concerned, patients who survived, their oxygen though did not change, but the oxygen requirements had come down significantly. This was a CRP before and after among survivors as compared to patients who did not survive. We found that patients who survived, there was a significant reduction in the CRP before therapy as compared to after therapy. But those patients who did not survive, there the CRP level did not either decrease or there was a paradoxical increase in the CRP levels. LDH, again, those patients who did not survive the reduction, there was not a significant reduction in the LDH levels. Similarly, if you look at the D-dimer and the SpO2, the SpO2 values in patients who did not survive had actually gone down, and those who survived, the SpO2 did not change, but the oxygen requirements significantly decreased. Now, the overall data, if you look at, there were about 21 patients who were discharged, including the patient who was on ECMO. She was discharged and she's come back with a fairly good recovery. 4 patients died. So if you look at the, calculate the mortality, roughly in the autologous bone marrow stem cell therapy group, it was about 16% as compared to about 32% in the standard of care in our ICU during that period. Which kind of made us think that this could be a potential therapeutic intervention that can be tried out in patients with severe COVID-19. Yes, we can debate and argue about the small numbers, but then again, given the pandemic scenario, this was something which was really encouraging, and where we had seen dramatic responses with respect to reduction in the respiratory distress, with respect to the reduction in the oxygen requirement. So this was something that was a very, very encouraging result. However, having said that, mesenchymal stem cells in COVID-19 seems to be having a role, definitely, but we still need to explore a lot of things. Now, what would be the optimal timing? Well, just like any other intervention, would early administration of stem cells be better is something that we need to look at. The dose is something that again has not been very, very clearly specified. Even in our own patients groups, there were some patients where we gave 2 sessions of bone marrow, and there were a couple of patients where we gave only 1. I mean, a couple of patients improved very, very dramatically with 1 session, so we were not sure whether to give the second dose, so we are still not sure what should be the dose. Viability, especially when you're giving the mesenchymal stem cells or the bone marrow, we know that some of these stem cells can be kind of killed by the macrophages or phagocytosis. We do not know for how long these stem cells are going to be in the circulation. And does the source of the stem cells matter, whether you take it from the cord, adipose tissue, bone marrow? Does one type of stem cells are better than the other is something that we need to look at. What would be the effect of preconditioning and what kind of patient selections would be required. Yes, we did it based on the humanitarian grounds, but do we have any medical, legal, or ethical issues, something we need to look at? We did check out the fact, or with a few people who had been using bone marrow stem cells extensively for other indications, where they said that most of the times, it's a well accepted intervention. Well, cost, if you're using mesenchymal stem cell therapy, well, the cost seems to be fairly high. But for us, when we looked at the bone marrow as a source of stem cells, the cost had come down very, very dramatically and significantly. And ultimately, we need more data before we can say that this should be something which should be routinely applied or becomes a standard of therapy, or at least an intervention which can be offered to patients with severe COVID-19 disease. Thank you so much for the opportunity. Thank you.
Thank you so much, sir. Now I request Dr. W4C2021 ma'am to introduce the third speaker of the session.
Who is introducing Dr. Nida?
Ma'am, I request you to introduce the third speaker of the session.
So let's welcome Dr. Anand Kilje. He's the Director, MCRI ICU Associate Professor of MGM Medical College, Aurangabad. Dr. Anand works as a Chief Coordinator of the COVID unit since March 2020, and he has been an Executive Committee member of ISCCM for less than 5 years. He's the lead author on aerosolized antibiotics in Critical Care Update 2017 and is an instructor for many courses. Welcome, Dr. Anand, and he'll be speaking on the semi-urban experience from Maharashtra on his COVID experience. Thank you, Dr. Anand.
Hello, everybody. Thanks, organizers, for giving me an opportunity to share my experience from semi-urban Maharashtra during this COVID pandemic. Aurangabad is a tier 2 city in mid of the Maharashtra. We got referrals from nearby cities like Jalna, Parbhani, Beed, Vidarbha, and Jalgaon. We have 2 medical colleges of 500 plus beds, nearly 7 corporate hospitals with more than 100 beds capacity. And there are small number of hospitals which are ICU beds of 8 to 10. We started thinking at our hospital level during April 2020. And we actually estimated that around 300 beds and 150 ventilators are only available in whole of the city of 15 lakhs population. And we were really wondering how we'll manage if number goes up rapidly. And at the same time, we started getting news that during the first COVID wave, Aurangabad toll was rising. Education is very important for any war. We prepared ourselves and our co-workers with training and understanding of virus transmission, training about donning, doffing, N95, use of PP. Motivation of everybody in the hospital was a challenge, particularly doctors, even senior doctors. So we did a lot of motivational talks, discussions, and knowledge sharing platforms. And then to fight this war, we don't have very effective drugs in the beginning of this pandemic. We are left with only oxygen support system with NIV, HFNC, and ventilators in initial period. Self-protection is a big challenge in the beginning, and we used industrial suits as a PP, as shown in the figure. Such suits were reused after autoclaving because of the limited stock. Even N95 masks were reused. We have only single video laryngoscope, which was not used very frequently, so nobody was very familiar with it. No negative pressure room, no isolated rooms. And HFNC and NIV was the only option for hypoxic patient with a high risk of aerosolization. Who should admit and treat the patient? Initially, only government hospitals were recognized as the dedicated COVID hospitals, and private hospitals kept distancing from admitting this patient. So it was not fair on our part to put only government hospital workers under a risk of health exposure. So if we are not able to treat, who will treat this patient? So we, team of 5 intensivists at MG Medical College, came together, had a detailed discussion and debate whether to treat this patient or not in very early phase of pandemic. And if we not, who will take care of this patient? And as a doctor, I thought this is our responsibility. We took a meeting of important doctors of all hospitals from our city, and I asked one simple question, that if anybody of you or your near one gets an infection and unfortunately it's an ICU, where you will admit and what standard of care you will give. This small question actually made a big difference. So one of our intensivist colleagues said, sir, we'll fight, we'll definitely fight. Zindagi badi honi chahiye, lambe nahi. That the dialogue of Amitabh actually motivated us. Soon we faced the situation where one of anesthesiologists from our city, his mother got a suspicion of COVID with a saturation of 70, moving one hospital to other without getting admission. She was an obese lady with hypothyroid. She got admitted with us, and we intubated that lady because she was very tachypneic and hypoxic. At that time, the notion was intubation is equal to infection. 100% doctors will get infection if we intubate the patient, and intubation is death. But this patient, after a lot of fight and ups and downs, recovered and went home. In fact, whole family of that doctor went home. And this was a moment of satisfaction and gratitude, and which actually motivated us to tackle the situation aggressively in the intensive care unit. So we started working on it. The teamwork, without saying, was important part at all the levels, from bedside, clinical people, supporting staff, administrative staff of the institute, and district administration, including CM and healthcare minister, who is from our area. They helped us during this high peak time and crisis, and just on our phone call and request, they supplied ventilators at midnight. The first wave was with a dilemma of treatment and fear of infection. The n number of drugs were used that are listed in my slide, and there was too much discussion about SCQS, and WHO actually ultimately halt the style of SCQS and proved to be a non-effective drug during this first wave. Second wave was much more horrible than expected because of outburst of number of patients, no beds, no ventilators, lack of oxygen, difficult to get a common drug like remdesivir, tocilizumab, even midazolam and atracurium, vacurinium. Doctors worked from first wave, got tired with the supporting staff and got burnout, and that was a challenge. The second wave, the treatment dilemmas got somewhat clear. The role of steroid, heparin, antiviral drug and immunomodulators got some clearance in a lot of studies. Still, a lot of unproven drugs were used, including high dose of vitamin C, and unfortunately, antibiotics are used rampantly. This is a paper cutting where it shows the crores of turnover occurred during a first wave about the antibiotic misuse. ICUs were started at every possible place in the peak period. In fact, hospital, nursing home, hotels, marriage halls became in new ICUs. Small ventilators were used for treating seriously ill ARDS patients, patients managed by all specialty of doctors. And in fact, the patients are managed at the terminal stage, and then they were asked to get shifted to a higher center, and a lot of patients have died during even transport. Whether to intubate these critically ill patients or not was a big dilemma at that time, and a lot of people in our part were hesitant to put patient on ventilator. High mortality, yes, of course it was there, in intubated patient, even at metros, but we have seen a good survival even after timely intubation of this patient. So we made a lot of doctors aware that go ahead and intubate when they need it. So this was a paper cutting again to make people aware that ventilator is a life-saving equipment and just use it when they need it. The semi-urban area, why this problem we faced? Because of less number of confident intensivists, limited ICUs, ventilators, and 10 manpower probably. NIV and HFNC, they use overuse basically during second wave, and without understanding basically who will be benefited with this modality and what are the limitations of this modality. And we faced a serious crisis of oxygen. There's a young boy who got admitted in newly started COVID ICU, required an NIV, and he was asked to shift at odd hour of 6 a.m. because of the oxygen supply got exhausted. By the time ambulance reached and take this patient for better care, patient collapsed and got arrested. This is just to highlight how patients were managed without adequate preparation in semi-urban and rural part. The oxygen, a life-saving drug, then guidelines were changed. The HFNC use gone down. Task force recommended not to use HFNC. Oxygen targets were revisited, and even our own hospital put back the high flow machines in the store. A lot of deaths probably would have prevented during this pandemic in semi-urban and rural part with optimal standard of care, good intensive care, intensivists, trained doctors, trained and adequate number of staff, and probably rational, timely use of drugs and ventilator. The intensivist, ICU trained doctors and nurses is a big issue in semi-urban part, probably in every part of the country, not only in Maharashtra. The most of the ICU are managed by the resident doctors in medical colleges and the trained BMS, BHMS doctor in small ICUs. Physician anesthesiologists who are not really trained in managing critically ill patients and ARDS patients, they were on duties. The nurse-patient ratio was very poor in semi-urban ICUs. Training of nurses was a big problem, and very few ICUs were monitored by the intensivist. This is the way we use technology, having photos of the monitor, ventilators, treatment charts and investigation, and which was very effectively used during crisis period. And we used to get reports at home, and we could support our treating team from home. Infection control practices were out. Secondary bacterial infection actually caused more mortality, increased length of stay and cost. Affordability of healthcare in semi-urban Maharashtra, in fact, in all parts, probably is a big challenge. Can we offer good quality of care in reasonable cost? That is the question. Many patients from semi-urban rural area are really not affordable. Government actually tried to put some restrictions on the private hospitals. Government has got a lot of schemes which are having a lot of limitations of their packages to use for critically ill patients with multiple organ failure patients, and insurance was also not very adequately supported the society during this pandemic. Transport facility, well-equipped ambulances were very less. Trained transport teams absolutely hardly available in rural part and semi-urban part, and shifting critically ill patient probably with low oxygen saturation with shock was a difficult challenge, and patient could not be shifted because of the inadequacy of good ambulances and trained manpower. So my experience is during this whole first and second wave that we have got a lot of limitations and even good strength of our health system. So understand the limitation and we need to try to improve it. Sometimes we had a very worst experience of pressure from the patients, number of patients, their relatives, politician, administration. Sometimes we are satisfying experience of recovering patients and their appreciation. We felt helpless at times. We cried at times seeing the deaths of young patients, had frustration sometimes, and we need to support each other. And as a team leader, I had to boost everybody when somebody is down in our team. Confusions of the treatment needs to be tackled at higher level, and exploitation should be avoided at medical practice. So what made us to work hard during this COVID pandemic is recovering patient and their appreciation. So this is one of my article published in local newspaper that bare honare patient he's amchi shakti. That is mean by recovering patients and their smiling faces and their satisfying relatives are only our energy to continue to fight in the COVID pandemic. So my take home at last is semi-urban part of the country needs more trained intensivists and trained nursing staff. Affordability to be addressed at policy level. Government schemes needs revision for good standard of care. Rational use of drugs, investigation and oxygen really will reduce the cost and deaths. Effective use of telemedicine will help rural and semi-urban doctors for better management of the patient. Thank you.
So much, sir, for such a comprehensive talk. Now I request Dr. Harsh Sapra to introduce the fourth speaker of the session.
Good afternoon, everyone. Let me take the opportunity to introduce Dr. Mohan. Dr. Mohan Gurjar is Additional Professor, Critical Care Medicines, SGPGI. His published articles, more than 150 published articles, and is instrumental in collaboration with IIT Kanpur regarding evolving medical devices. He is the national representative for various international studies, the member of Item Writing Committee, and the member author PACT module ESICM Europe. So he would be speaking on post-COVID reactivation of old opportunistic infections. Welcome, Dr. Mohan.
Good day. In this talk, we will discuss about the post-COVID reactivation of cytomegalovirus. Cytomegalovirus or CMV in critically ill patient is usually considered when there is an immunocompromised state. Either patient is on immunosuppressive therapy or because of disease per se. While CMV infection in immunocompetent, there are very less evidence available. CMV infection can involve any part of the body and the manifestation might be non-specific. It can involve the liver, can involve the esophagus, GI tract, or lung itself. Everybody has exposed to some extent for this viral infection throughout their life. In the Western world, by the adulthood, 50% of population are the CMV seroprevalent for the IgG positive. While in India, the seroprevalence is a much higher, means all of us in the about 90% populations are having CMV infection in maybe in the early part of our life. So we have a CMV IgG positivity. So this CMV infection, or you can say cytomegalovirus reactivation, happen when there is an acute illness, even in the immunocompetent population. In last few years, few literatures are started to appear. People had tried to study the CMV reactivation in general non-immunosuppressed ICU populations. So this published in 2015, and this group studied CMV reactivation in the mechanical ventilated patients who were seropositive, means IgG positive. They look for the reactivation of CMV at the time of admissions who require ventilator support, and then They followed weekly till the next 4 weeks. Reactivation happened in 14% of their populations, and usually these patients have a reactivation after the 1 week of ICU stay, and it was very well correlated with the severity of organ dysfunction. Next year, 16 very good and large studies among the ARDS populations, where the investigator looked for the reactivation in patients who develop ARDS. They looked the CMV reactivation through PCR in plasma at the time of as per the inclusion criteria, then followed weekly basis. They found 1/4 of the ARDS patient had CMV reactivation. Here also, they found the reactivation happened 1 week after the admission or inclusion in their study, and it was independently associated with the increased case fatality. In 2017, another large study published from the same Netherlands group who had studied in the ARDS population. Now they look specifically septic shock population, more than 300 populations. So here they look for the reactivation of different herpes viruses, including CMV, Epstein-Barr virus, human herpes virus, herpes simplex, varicella zoster virus. 2/3 of these patients, septic shock populations, they had a reactivation, and it was found independently associated with the mortality. And it happened more when there is a more than one virus got reactivated. 2018, one researcher group had looked for specifically what happened, why are these patients in whom the CMV reactivation happened, they are different in whom the CMV reactivation did not happen. So they look specifically the various markers, interleukins, but they could not find out the difference in the severity of these inflammatory marker manifestations in both group, means reactivation group and no reactivation group. And contrary to the previous studies, they did not also find any difference in the mortality. So what are the evidences among in the COVID-19 patient? As early as June 2020, the experts, they expressed their views published in Medical Virology Journal. They found the few COVID patients have a more severe in the severity, and they postulated there is a potential role of the CMV reactivation. Another commentary published in Immunity and Aging March this year, where they found that the high possibility of severe COVID because of the CMV reactivation. But what are the actual evidences? One of the small studies published in the Infectious Disease Now this year. So the researcher, they presented their paper in the lab for whom they received the sample process for the herpes simplex and CMV reactivation or Epstein-Barr viruses. They found in the COVID patient for whom these herpes virus viremia has been assessed, 80% of the time there was a high copies of these viruses, means high reactivation, more than 80% in the COVID populations, and it was associated with the longer length of the stay. This small study done at our institute in collaboration with the Department of Microbiology and presented in the European Respiratory Society last month. And we looked for the CMV reactivation in COVID-19 patients who had ARDS. We had 23 enrolled for this study, And out of them, in 21, they already had IgG seropositivity for CMV. Out of 21, 8 patients shown CMV reactivations, means around 1/3 of the population has a reactivation for the CMV, and all of them, they died. While among the 13 patients who did not show CMV reactivations, 85% was the mortality. The further analysis of this data is pending. What are the risk factors which could lead to the CMV reactivation in apparently immunocompetent ICU populations? There is a strong association has been found with the presence of sepsis and ARDS, while the weak risk factors are considered use of steroid and blood transfusion history, while there was no association has been found in terms of the age, disease severity, or presence of active malignancy. The few randomized control trial has been seen for this CMV reactivation with the antiviral therapy in ICU population. If we see, because by this time literature has suggested 1/3 to 50% population might having the CMV reactivation. So in this RCT, they try to give the antiviral, means ganciclovir, to all of the ICU populations who are apparently immunocompetent. So in the follow-up, they find out that definitely the significant reduction in the percentage of reactivation in whom antiviral ganciclovir was given, while there was no difference in the mortality has been found. Another study again published in the JAMA 2017, where they look for the safety of this antiviral ganciclovir therapy in immunocompetent ICU populations. So they did not find any difference in terms of the drug side effects. Either you give ganciclovir or you did not give the ganciclovir, though reactivation was significantly low in the patients who had received the ganciclovir therapy. 2019, again published in the JAMA, where the acyclovir was given in the ICU populations, where herpes simplex virus was reactivated, and patient's cohort was the mechanically ventilated patient. So in whom the acyclovir was given, and they followed for 60 days ventilator-free days. They did not find significant difference, while they find that mortality is significant less in whom the acyclovir was given among the population who had this herpes virus reactivation. While current year 2021, another RCTs was done among the CMV reactivated populations, where preemptive ganciclovir was given and compared with the placebo. So here it is a contrary to the previous study, the mortality was not different. Either patient who received the ganciclovir or received the placebo, the group was the CMV reactivated population. Also, there was not a significant difference in the ventilator-free day. So take-home message about the CMV reactivation in apparently immunocompetent, critically ill patients, including the COVID-19 population, that we should know there is a high seroprevalence, especially Indian populations, and the CMV reactivation can present non-specific signs and symptoms, but how much we should take as evidence, we don't know. There are unanswered questions. Does viral reactivation cause clinical deterioration, or it is a simply innocent bystander? Is prophylactic or preemptive antiviral treatment effective in reducing morbidity and mortality? We don't know at this point of time. So we should not use the antiviral means cyclovir therapy, even the patient who had shown the CMV reactivation. We need more evidence before we start to treat CMV reactivation in apparently immunocompetent population. Thank you.
Thank you so much, sir, for a wonderful talk. Now the session is open for question and answers.
A small question. I think this was a very good discussion by all the expert speakers here. There's a small question to Dr. Mohan Gujar. So when we talk about the reactivation of various infections, old infections, you very nicely talk about CME. Similarly, the reactivation of the various cancer-related things has also happened. Those patients who are very stable, so they, because of the immunomodulation and all those things, there was reactivation or resurgence of these cancer-related issues. So can you just comment upon COVID and why this interaction happened at stable patients in remission has the cancer activity coming again? Dr. Gujar, please.
I think Dr. Gujar has left, is it?
It appears, I think, yeah, maybe.
Can I ask a question to Dr. Ghansham?
Yeah, please.
Yeah, so actually the whole session was excellent. All the lectures were really very informative. Dr. Ghansham, I just wanted to ask you, what are the long-term implications of this stem cell therapy, especially when it comes to graft versus host disease and all, because those are the things we are really worried about in these patients. And secondly, I mean, we really don't know whether this stem cell therapy, because all your patients were younger patients and without comorbidities. Do you think, yeah, whether it worked as a placebo? Just a thought, like, yeah.
See, as far as the long-term effects are concerned, I don't think there are any long-term effects because not only in COVID, if you look at a lot of other conditions where stem cells were used. In fact, there are a lot of data which has established the fairly safety profile of the stem cell therapy, and in fact, there are data where the stem cells have been shown to decrease the incidence of graft versus host. Now, in our case, since we are using autologous bone marrow, I mean, the patient's own bone marrow was taken, so the question of having a GVHD was practically ruled out. Could there have been a placebo effect? Well, I do not know. But, see, having seen so many COVID patients in the last 1.5 years, I know we all believe in science, but we also believe in a few instincts that we all, on a day-to-day life, kind of feel that. Now, there were patients whom we never thought that they were going to make it. What was very assuring was the rapidity with which the distress and the oxygen requirements had come down in a few of those patients. We never saw that kind of a decline in the respiratory distress or the oxygen requirements in any other patient where stem cell was not given. Yes, patients did respond in the standard of care, but the response was much more gradual. In the stem cell therapy group, there were a few patients where we could find, we found a very, very dramatic, reduction in their oxygen requirements or the respiratory distress, and the CRP almost, the next day had come down to more than half or decreased by more than half. So, and this and we all would agree to the fact that the the therapy during COVID centered around immunomodulation, and the immunomodulatory effects of stem cells have been well proven. I still think that there is a potential role for this. This needs to be explored further. We are hoping for a prospective trial in a proper way and see if this really gives us that extra edge and acts an adjuvant to the already available armamentarium.
Absolutely, absolutely. It's definitely worth trying effort, definitely. So thank you, Dr. Kansham. That was really interesting study. Yeah. So can I ask one more question to Dr. Anand? Yeah.
Yes, please.
Yeah. So Dr. Anand, that was a very nice introspection into the way you handled COVID with limited resources. So do you think that in this kind of setups, now there will be long-term changes, like people, the government and all, and even the medical community would be looking at making better resources available for future calamities? We hope none occurs, but just in case, like
exactly.
there will be long-term changes.
Yeah, that is the right point I think you raised. I think probably everybody, including the hospitals, organizations, and even government, has improved the infrastructure at all the level. Even our rural hospitals, like a small cities like Jalna, has got 100-bedded COVID center with an intensive care backed up by a telemedicine. So I think already people have increased resources, but unfortunately, number of trained intensive care people are lacking in a semi-urban part or rural part, and that needs to be tackled. At least when we need to train nurses and some doctors who will take care of this patient at primary level or secondary level, and then they safely transfer to the tertiary level of care. So that trained manpower is still a big challenge in probably semi-urban and rural part.
Yeah, absolutely. I think we need to attract more intensivists and the trained critical care nurses to come to such areas, work, and they should be encouraged and appropriately appreciated. Really. So that's great. Thank you very much. Thank you.
Yeah, thank you.
I think thanks to all the speakers, and the time is up. So it was a wonderful session. Many good carry-on messages that we could listen from our expert speakers and their own personal experiences. Thank you so much. Thank you, my co-chairs also, and we get back to the organizers for the next session. Thank you so much.
Thank you very much.
Thank you, Dr. Garg. Thank you.
Really
thank you, everyone. Yeah, thank you, everyone.
Thank you.
Thank you, everyone. Now I request Dr. Prabhat to proceeding the next session of the day.
Dr. Nida, can you please start with the introduction?
Dr. Prabhat is not here.
Good afternoon, everyone. Am I audible? This is Dr. Prabhat here.
Yes, you are audible.
Okay. Good afternoon, everyone. Our next session of the day, our next thematic session, let's begin with the next thematic session. And to chair the session, I welcome Dr. Nikhil Kothari, the additional professor, Department of Anesthesiology and Critical Care, AIMS, Jodhpur. Second chairperson is Dr. Pankaj Anand, senior physician, diabetologist and wellness expert, HOD Critical Care. Third chairperson is Dr. Pankaj Jain, and fourth chairperson is Dr. Urvi Shukla, consultant in charge, Symbiosis University and Hospital Research Center, Pune. Now I request Dr. Nikhil Kothari to introduce the first speaker of this session.
Yeah. Thank you, Dr. Prabhat. Can you hear me?
Yes, I can hear you.
Yeah. So good afternoon, all of you. So our first speaker for this thematic session is Dr. Rashmi Kapoor, and she is head of Department of Pediatrics and director of the Department of Pediatric Critical Care and Pulmonology at Regency Hospital, Kanpur. So good afternoon, ma'am, and I welcome you on this in this thematic session. And further adding to her credential is that she is the only pediatric intensivist with a special interest in pediatric pulmonology. That's really rare to meet such uh, uh, intellectual people who have done more than 100 pediatric flexible bronchoscopies, and she has removed more than 300 foreign bodies from the airway of children. That's really a commendable job done by ma'am. So Dr. Kapoor has special interest in pediatric chest radiology besides doing a pediatric flexible bronchoscopy. So I really appreciate her work. So I welcome you, ma'am, on this platform, and over to you, ma'am.
Good afternoon. Today I'm going to speak on pediatric bronchoscopy in the pandemic. Bronchoscopy is an aerosol generating procedure. In the era of pandemic, airway procedures can put healthcare providers at an increased risk of exposure and transmission of disease. It is critical, therefore, to stratify the patients requiring prompt bronchoscopic intervention and those where you can delay the procedure. Full PPE for the bronchoscopist and a modified face mask for the patient is recommended. There are certain emergent indications in this pandemic to do bronchoscopy, like acute foreign body aspiration, massive hemoptysis, and suspected airway compression or obstruction. There are certain urgent indications like pneumonia in immunocompromised patient, progressive pneumonia, difficult intubation, unexplained persistent wheeze, atelectasis, obstructing thick copious secretions of LTB, where you have to do a bronchoscopy urgently. There are certain acute conditions where you can plan a bronchoscopy within 2 weeks, like there is a lung mass or a nodule, you're suspecting sarcoidosis, or there is acute lobar atelectasis. Rest all the indications for bronchoscopy can wait for 2 weeks or do whenever it is possible. So I'll take you through all the cases which we did 2020 and 2021, where there was an emergent and urgent indications to do bronchoscopy. So a 2-year-old female with recurrent hemoptysis for last 2 months referred after the third bout of hemoptysis with respiratory distress and pallor. Immediate resuscitation was done. A CECT showed significant bilateral pulmonary arterial dilatation and calcification in the mediastinum. Echo showed PA, pulmonary arterial hypertension. Bronchoscopy revealed prominent pulsations on both the sides and hemorrhage on the left side. Since it wasn't a very severe hemoptysis, so the bronchial artery hemorrhage was excluded. We did a CT pulmonary angio. So pH was there, but there was an extra cardiac mass which had a calcification, and our differential diagnosis was teratoma or any other mass, and this child is awaiting surgery. There was a 9-month-old child with sudden onset of severe loud stridor. Suspecting a foreign body aspiration, we did a bronchoscopy. So bronchoscopy revealed anterior compression of upper trachea, and there were visible pulsations here. Thinking it could be a pulmonary arterial slaying or a double aortic arch or any kind of a vascular ring. We did a CT angiogram. CT angiogram was normal. So we did a CCT thorax. which revealed a large cystic mass in the mediastinum, in the superior anterior mediastinum, and it was compressing the trachea. So we sent this child over to cardiothoracic surgeon. Surgery was performed, this mass was removed, and it turned out to be a large cystic hygroma. A 2-year-old male came to emergency at 1 a.m. with severe respiratory distress, severe respiratory acidosis. He was intubated and ventilated. There was bilateral pneumothorax, bilateral ICD was put in. AVG still showed severe respiratory acidosis. So there was no improvement. So we planned a bronchoscopy. So there was a foreign body in the right main bronchus. And another one in the left main bronchus. So they were bilateral foreign bodies, and we removed it with the flexible bronchoscope. There was a 4-year-old girl who came with complete loss of voice to our emergency. The father said that the child was speaking some time ago. He started whispering, and now there was a complete loss of voice. We did a bronchoscopy. And here you go, you see the paralysis of left vocal cord. So bronchoscopy revealed paralysis of left vocal cord. The entire household had had COVID-19 6 weeks ago. So was it because of COVID-19? We don't know. A 2-month-old child came with severe stridor and poor weight gain. He had been on ventilator for 7 days in the neonatal period. So bronchoscopy was planned. And we can see there is a subglottic stenosis. Here you go. This is a pinhole subglottis. So there was a acquired subglottic stenosis in this child. We did a balloon dilatation, and the child is okay. A 1-month-old child came with respiratory distress since birth, but the distress had increased tremendously. We did a bronchoscopy. And here also we can see a subglottic stenosis. This is a cartilaginous subglottic stenosis. A cricoid split was planned in this child, and he was okay. A 5-year-old child with stridor and severe respiratory distress with impending respiratory failure presented to our emergency. He gave a history of severe respiratory distress earlier. A bronchoscopy was done, and it revealed papillomatosis. So there was a recurrent extensive papillomatosis. This child needed tracheostomy. A 10-year-old child with bicycle handle injury came with respiratory distress to our emergency. We did a bronchoscopy. It revealed a tracheal tear. This is a tracheal tear, and this was repaired by the ENT team, and he was discharged. 8 years sick female came with complaints of vomiting and persistent cough for last 2 months, bilateral, severe retractions, X-ray chest was normal. We did a bronchoscopy. And what do we see? Something coming out from esophagus into the posterior trachea. So it so happened that they gave a history that the child had swollen, had taken in, ingested a button battery 2 months ago, and she had forgotten about it. And this has eroded into. So the entire team repaired it, removed the foreign body. 15-year-old child, 70 kg with fever for 1 month, came to PICU with seizures and hemiparesis, visual disturbance. X-ray showed bilateral pulmonary edema, and he had hypertension. We diagnosed as press and treated accordingly. X-ray 2 days after admission was clear. However, there was incessant cough and had expiratory wheeze. So we did a bronchoscopy. A bronchoscopy revealed complete external compression of the left main bronchus. This complete compression. So there was something pressing from outside. So we did a CT angio and see what we find. There are dilated carotids and arch of aorta. So it was a case of Takayushi arthritis. A 4-month-old child with giant cystic hygroma at birth, tracheostomy was done at birth. So he came for evaluation of tracheostomy tube, whether we could remove it or not, because the tracheostomy tube was in for last 4 months. So we see that aryepiglottic folds are still very edematous. Epiglottis was also very floppy. Here is the tracheostomy tube right there. There are certain granulation tissues over there, but we suggested that we cannot remove the tracheostomy tube because the aryepiglottic folds were still very, very floppy and there were few cysts still remaining. A 1-month-old child on ventilator, post-extubation respiratory distress, X-ray showed right lung white out and trachea was shifted towards this. So this was a right massive acute atelectasis. So we did a bronchoscopy. So we see secretions in the right main bronchus. The secretions were cleared and collapse was also cleared. A 5-year-old child came cyanosed, severe respiratory distress, almost going into respiratory arrest. He was intubated and ventilated. X-ray chest, see, it showed as if there was a foreign body. So we did a bronchoscopy through the endotracheal tube. And here we see thick, copious secretions in the left main bronchus. And we removed those secretions, and what came out was a cast. A 10-year-old Down syndrome with severe respiratory distress and impending failure, intubated, ventilated, but did not improve. We did a bronchoscopy. So there is laryngomalacia severe and bacterial tracheitis. See, there are such thick, copious secretions bilateral. So bronchoscopy revealed adenoidal hypertrophy, laryngotracheomalacia with severe bacterial tracheobronchitis, and BAL revealed Pseudomonas, more than 1 lakh colonies. We treated, sweat chloride test was negative, and the child became all right. A 5-month-old with severe respiratory distress for 8 days was getting cyanosed and referred for evaluation. So we did a bronchoscopy. And what do we find? There is a foreign body sticking out at the glottic opening. So this was a peanut peel. This was a peanut peel. The whole peanut was shoved into the mouth of this small child by elder brother. And had he not come to me that day, the child would have been dead by now. 5-year-old kid with seizures receiving 3 anti-epileptic drugs. The seizures persisted and he landed in PICU in status epilepticus. After taking a detailed history, a bronchoscopy was suggested. And look what bronchoscopy revealed. So there was a bead in the subglottic space. And this child gave a clear-cut history that he used to feel that something was coming up, and when the bead got blocked with secretions, he used to have hypoxic seizures. So bead was removed by a flexible bronchoscopy. So we can say that flexible bronchoscopy is a powerful tool to peep into the airway. It is an aerosol generating procedure, so should be done with all precautions. Each PICU should have easy accessibility to flexible bronchoscopy, and airway management is the commonest indication for urgent bronchoscopy. Thank you.
Well, I would like to thank Dr. Rashmi Kapoor for such a comprehensive talk on pediatric bronchoscopy and showing us different scenarios. Now, I would request Dr. Pankaj Anand to introduce the next speaker for this session.
Hello, hello. Can you please introduce Dr. Dhiren?
I request Dr. Pankaj Anand to introduce Dr. Dhiren Gupta, who is the next speaker for the session. Dr. Pankaj Anand.
Dr. Pankaj Anand is not here. We can proceed with the next chairperson.
Can we proceed for next?
Okay. Then coming to the next, I request Dr. Pankaj Jain to introduce our next speaker for the session, that is Dr. Nirmal Choradia.
No, we can just another person can introduce the Dhiren Gupta. Is this possible?
Yes, it is possible.
They
Dr.
can do this.
Dr. Prabhat, Dr. Urvi is here. Dr.
I can introduce.
Yeah. Dr. Nikhil Kotari is here. So they can introduce Dr. Dhiren and then.
Yeah, so I would request Madam, please go ahead.
Okay, thank you so much. We welcome Dr. Dhiren Gupta, who is a senior consultant in pediatrics at Sir Gangaram Hospital, New Delhi. After completing his MD in pediatrics, he has trained intensively in Australia. He also specializes in the treatment of chronic diseases like chickenpox, measles, and jaundice. And he handles pediatric emergencies and takes care of critical situations with ease. All his work is focused at Sir Gangaram Hospital. We welcome him. Dr. Gupta, the stage is all yours.
Hello friends, and the next 12 to 15 minutes I'm going to talk about multi-system inflammatory syndrome, and specifically I'm going to focus on the management part. We all know that in pediatric population, the acute COVID is not of a major problem, but definitely after 2 to 4 weeks of the acute COVID, in 10% during acute COVID also, they land up in a multi-system inflammatory syndrome. And this can be life-threatening in almost 50 to 60% of the patient. Aim in this presentation is I'm going to talk about high-risk feature which require referral in intensive care, especially level 3. And most of the patient can be managed even at a nursing home level, even a small ICU setup. So what is MIS? As name suggests, it is an abnormal immune response to the virus, which has got similarity to specifically to the macrophage activation syndrome. Right, in some of the patient, it may present like a Kawasaki disease, and it is basically a cytokine release syndrome. We all know that during initial period, it's not a pediatric major concern when SARS-CoV virus infection mainly lungs affect the lungs in the adult population. But after a lag period, it lands up in cytokine storm, which can affect the vasoplegia, can lead to shock, it can lead to acute myocardial injury, and specifically it can lead to coronary dilatation, and it is immune related, super antigen related, it's very difficult to interpret. Let's go through our data when we talk about clinical features. As you can see, these are 90%, 90 patients over past 3 months, and the average age is little bit on higher side, around 8 years. Though it's not uncommon to have a young child, a young infant to have MISC, mainly involved in male. And regarding systemic involvement, mainly it is the gastrointestinal in pain in form of pain in abdomen and the vomiting, loose motion like toxic shock syndrome. And the main significant thing is almost 50% plus develop cardiac involvement in present, they present as a vasoplegic shock or cardiogenic shock. In many of the patients, they do develop respiratory, but pneumonia per se is less common, but mainly it is pulmonary edema due to cardiac involvement. In some of the patients, as I told you, it may be like Kawasaki, like in our series was 43%. In few of the patients, maybe hepatic involvement, CNS involvement, and renal involvement that is not very uncommon. When we talk about laboratory value, we all know that what is inflammation, high TLC, polymorphic count. So same way we find that in many of the patient, TLC is a little bit on the higher side. Platelet may not be high, may be low in many of the patient, but very significant is very high CRPs, very high procalcitonin, though it is not in bacterial infection. And significant thing is ferritin in some of the high ferritin in some of the patients, especially who present with an HLH type of picture. And as compared to adult, IL-6 and LDH is pretty high. You can see in adult more than 100 IL-6 usually is an alarming, but in MIAC, most of the patients do have IL-6 more than 100 to 200. As comparable to adult, D-dimer is going to be high, but we need not to give anticoagulant to these patients. In few of the patients where your coronary dilatation is there, where your cardiac function is poor, you need to give anticoagulant. And very significant as compared to adult COVID problem is a high pro-BNP, that is cardiac markers are pretty high. You can see in our data, it was more than 10,000 in most of the patients. And echocardiography will show abnormalities in form of left ventricular dysfunction in almost more than 50% of the multi-system organ involved patient. But the good point about pediatric MIC, despite they require tertiary level ICU, that only just 2 patients expired out of 90. So outcome is pretty more than 95%. That is the beauty of pediatric MISC. We need to understand a lot of differential diagnosis. When we talk about MISC, it usually present after 2 to 5 weeks of the acute COVID infection, but it's a diagnosis of exclusion. The main differential diagnosis which we need to keep in mind, like scarlet fever, dengue, toxic shock syndrome, Kawasaki disease, present with fever with rash, scrub typhus, again leptospirosis, which present with early multi-organ involvement. And of course, we should not forget septic shock, gram-negative sepsis, enteric fever, which can behave like sepsis. Patient can just not be just Kawasaki disease with eye congestion. Adenovirus leptospirosis can lead to eye congestion. Many surgical diseases behave like MISC, like diabetic ketoacidosis, appendicitis, pancreatitis, Epstein-Barr virus, cytomegalovirus, adenovirus. These are the other viruses which can lead to myocarditis. And SLE with other vasculitis also can behave like MISC. Very important is hemophagocytic lymphohistiocytosis should be differentiated from the MISC. In this HLH, cytopenia is a major feature with very high ferritin. Very high ferritin is usually not present in the classical MISC. It is the high CRP and high procalcitonin. Liver function tests are very abnormal in HLH as compared to MISC. And of course, neurological symptoms are there in HLH. Cardiac gastrointestinal symptoms are less involved in HLH or macrophage activation syndrome. When we talk about management, I'm going to show you some of the cases who presented with hypotensive shock. This is a 3.5-year-old who presented with hypotension on the left side. On the right side, look at the lips. It is red like in Kawasaki disease, again presenting with hypotension in emergency. This was my first patient after first wave of around 4 to 6 weeks after the first wave. Patient presented with vasoplegic shock, had pain in abdomen, had fever of 105, and on the right side you can see the coronary dilatation. Coronary score was Z score which we calculate was more than 3.5. Patient, while giving IVIG, land up in pulmonary edema that is manifested on the right side. Look at the ultrasound. It is presenting as an B line. Though chest X-ray is normal, that is a B shadow. C is a normal ultrasound. If you compare A and C, even a blind person can appreciate how much fluid inside the lungs are there. This is again a 9-year-old who presented with vasoplegic shock, refractory shock, requiring inotrope. Look at the IVC. This way nowadays we assess. This was a fluid refractory shock. This was a 2-month-old baby who presented with refractory Kawasaki disease post-MISA. And this patient was the only patient who required biologics to treat the MISA. We gave infliximab in this patient. So what are the relevant questions to the intensivist? One is the fluid refractory shock, which I showed you. Second is the vasoactive drug selection, and the arterial line is much required to select the vasoactive drug. Evaluation by ultrasound and echocardiography should be done. And dose of the steroid, what dose should be given? It should be 2 or 10 or 30. It depends on the severity. Should I give IVIG along with steroid or IVIG enough? If patient presenting with diabetic ketoacidosis, pancreatitis, you should give IVIG as a drug of choice. Otherwise, you can start with steroid. If present in shock, you can give 10 to 30 milligram per kg. If no shock, you can give 2 milligram per kg. If patient presenting with the Kawasaki, you can just give IVIG and low dose steroid, that is 2 milligram per kg. And the problem with the refractory MIS, which I am going to target, it is not well defined. And what should be the choice once IVIG failure has happened? So as I told you, most of the patients present with a fluid refractory shock. Norepinephrine is a drug of choice for the warm shock, epinephrine for the cold shock, that we understand even by the when we manage a shock patient, a septic shock patient, and how we evaluate our shock patient with ultrasound. Look at the coronary dilatation, look at the ejection fraction, look at the pericardial effusion. These are the factors which can affect, which can be, we should view in these patients with shock. Now we come to the dose of steroid. As I told you, this is a algorithm which you can call it a workable algorithm. A patient who is presenting with the shock in an emergency, put in a cannula, large bore cannula, give a fluid bolus, though it should be given slowly over 30 minutes, 5 to 10 ml per kg. As I told you, many of these patients are fluid refractory. And look at the hepatomegaly, look at the basal crepitation, look at the gallop rhythm and echocardiography available in the emergency, look at the poor cardiac contractility. If you find that of course this patient is actually in cardiogenic shock, you need to give an methylprednisolone, a 10 to 30 milligram per kg, may require intravenous immunoglobulin, and you need to start on epinephrine. If patient is in warm shock, that is vasodilated shock, you need to start on norepinephrine. If patient had normal perfusion, you can give methylprednisolone low dose 2 milligram per kg, arrange for the intravenous immunoglobulin. Till then, you rule out other differential diagnosis. So there can be many situations like patient is become afebrile after 48 hours, no recurrence of fever after 7 days, no organ dysfunction. So give methylprednisolone over next 3 days, reduce to 2 milligram per kg, then gradually wean over next 2 weeks. This is another situation. Fever is persisting after 48 hours, right? But the CRP has shown decreasing trend and there is no progressive organ involvement. You continue to give a little bit higher methylprednisolone over next 5 days, then you reduce it gradually. But you need not to give another dose of IVIG or don't think it is a refractory case. Now look at the third situation. Fever, not only fever is persisting, but when you are giving IVIG, CRP rather than going down, when you're giving methylprednisolone, CRP is increasing. There is increase in vasoactive scores. These are the patients who may require second dose of IVIG or may require high dose of methylprednisolone. If at start you have used 2 doses, lower dose of methylprednisolone. Now, very important is organ support. Suppose a patient who is coming late, he is presenting with vasoplegic shock, he is presenting with hypotension and cardiogenic involvement. these patients may require extracorporeal membrane oxygenation, right? And may require respiratory support because of pulmonary edema, may require CRRT if there is a positive fluid balance more than 10%, not responsive to furosemide, may not have AKI, but CRRT may be required, especially filtration system like oxalase or cytosol filtration. And if there is a persistence of inflammation, these type of filtration can help. Now, the last question which I'm going to focus, can I predict the severity of disease? That is shock a patient I have admitted in nursing home. I'm worried, should I refer this to tertiary center? So to support this, this is our data of the North India, which was published in Indian Journal of Critical Care Medicine in October 2021. We had 120 patients, median age of 7 years again. 73 out of 120 children presented with the shock, 63 required, means 52% required inotrope support and 51 required respiratory support. And when we analyzed this data, we found that again it was gastrointestinal mainly, followed by cardiovascular, mucocutaneous, respiratory, hematological involvement, and again very few deaths. And can we predict the severity in these patients? That is my question. What we found that if a CRP is more than 100 and ferritin is more than 200 with high D dimer, very likely these patients may end up in severe disease. So look at the first CRP. If it is more than 115, and if you find means the NLR ratio is more than 5.9, very high chances this is a red marker that this patient is going to end up in problem. Alone CRP, if it is more than 300 at the start of disease, then it means a fourth day or fifth day, it indicates that it is going to be severe disease. So bigger the child, say around more than 9, 10 years, high CRP, that indicates that very likely these patients can land up in problem. If I summarize my whole presentation, there are high risk features like refractory shock, high CRP, especially more than 200 to 300, high procalcitonin, cardiac dysfunction, high ferritin, severe pain in abdomen indicates severe disease. So concluding my presentation, early recognition of life-threatening MIs is important. Overdiagnosis, misuse of steroid, IVIG, or unnecessary use of an expensive drug should be avoided. And over the years, we have found that steroids only in many of the patients is good enough. High dose steroids should be used in only in critical patients. Try to rule out differential diagnosis before you give steroids. If you land up in pancreatitis, diabetic ketoacidosis, try to avoid steroid. And of course, we need good indigenous prospective studies to define our queries. Thank you very much for the patient hearing.
I would like to thank Dr. Viren Kumarji for such a comprehensive information about MISC. Now, I would request as a chairperson, Dr. Nikhil Kothari, to introduce the next speaker for this session. Dr. Nikhil is there.
Another chairperson can introduce.
Dr. Urvi Shukla, I request to introduce next speaker for this session.
May I request Dr. Kundan Mittal, a very warm welcome to World Conference on COVID Critical Care. He's Professor and Head Unit 3, Department of Pediatrics at PGIMS Rohtak, Haryana. And he has been awarded the Fellowship of Indian Academy of Pediatrics and the Fellowship of Critical Care Physicians in 2016. Over to you, Dr. Mittal.
Okay, good morning. I'll be talking for the pediatric consideration in ICUs. So, like we get a call in emergency, like cases coming like 6 years old male child brought with history of fever 3 days, rash, chest on the chest 2 days, altered mental status, irritable to touch, lethargic, BP is hypotensive, respiratory rate is 30 per minute, subcoastal retraction. So we get this type of information and call from the doctors or referring doctors. So what we want to know in our presentation, identification of assessment of sick child, what are the difference between child and adult care, what are the normal vitals, because in emergency or in ICUs, we play with the vitals only. We are not after the diagnosis of the patient. What are the system differences between adult and child patient? So common conditions like we see in pediatric population, respiratory disease are more common compared to adult. Infections are also more common. We get the cases of status epilepticus, multiple trauma, including TBI, diabetic ketoacidosis, acute liver failure, acute kidney injury. These are the common conditions which we come across in the ICUs, in pediatric ICU and common general ICUs. Okay, what is special about children? Children have dynamic physiology and their psychomotor skills and social skills depend on the developmental age stage of the child. So like 1-year-old child cannot escape from the fire, so from the poisonous gas. So these all features depend on the development stage of the child in the psychomotor skills. Appearance and expected behavior to illness also varies with the age, like that is not common with the adult population. Despite having similar genetic makeup, their expressions are different from adults. Children also have some anatomical physiological differences from the adults, thus making the preparation of equipments ready accordingly. This is very important. Moreover, children depend upon the caregivers for their needs. Disease pattern, as discussed, is different, and it is also important to monitor the weight and the height of the child, because we have to give the drugs on the basis of the weight of the child. And therapeutic and monitoring points are also different, and they should be defined for that particular age group, because the vitals are different for different age group. Traditionally, monitoring physiological status has been the basis of the assessment and treatment in acutely ill children. Acute illness results in physiological changes in almost all body organs, but we monitor only few. The development of the severity of illness as well as recovery is paralleled by change in the physiological variables. Physiological responses seen in acute illness are increase in heart rate, which we monitor, cardiac output, peripheral vasoconstriction, altered metabolism of glucose, protein, and fat acid. So the changes in every organ of the body, but we monitor the few because for all we cannot monitor. So this is also important to know age-wise distribution, because the vitals, parameters, the requirements are totally different. The disease pattern is different. How to calculate the weight of the child, like 1 to 6 years, we do age into 2 plus 8, and 7 to 12 years, we do age into 7 minus 5 divided by 2. This is important when you are calculating the drug doses. So, and age distribution is also important to know, because the disease pattern is different for different age group. Like sepsis, newborn have more common sepsis, hypothermia, hypoglycemia, more common. So H influenza is more common between 1 to 3 years age. Injuries are common in school-going age, children are adolescent, drug addictions. So we have to know the age distribution, and calculation of height is also for the 2 to 12 years age into 6 plus 77, we can calculate the height of the child. So this is also important. Children have large body surface area, hence likely to become hypothermic when exposed to extreme conditions. Water loss is more due to thin skin, so they are more prone to dehydration. Hypotension, which is a late finding in children as compared to adults, as they have good capacity to compensate. And for shock, tachycardia is the earliest sign, which though we can have tachycardia because of anxiety, because of fever, for so many other reasons, but early signs of shock is tachycardia. Bradycardia is a sign in sick child. So ligaments are strong in children, bones are weak, so injury without radiological abnormalities are very common. Immature immune system, thus making them more prone to the infections. Tongue is large and important cause of airway obstruction in unconscious child, because larynx is slightly highly placed as compared to adults. Epiglottis is short and omega shaped, and cricoid ring is narrowest part 4 to 6 years of age, and lateral glottis become narrow part. Thus need for cricoid pressure in late stage when you are intubating the patients. Alveoli are also developing the late stage. FRC is small. Intrathoracic pressure is also low. Diaphragm is placed just like COPD patient in pediatric patients. or small children. Small airway, low FRC, and poor elastic recoil makes more prone to respiratory failure. This is very important. So body weight, we know why we are important to know the clinical consideration or treatment consideration is body weight. We have to calculate the fluid and the antibiotics. Entry fontanella usually close up by 18 months. This will give the status of dehydration or hydration status of the child. Activity level also depend upon the age. Persistence of neutral reflexes beyond certain age are abnormal. Body surface area is calculated for the because they have larger body surface area, so more prone to dehydration. Small upper and lower airways, so equipment requirement is totally different. We need state bed up to 20 kg of the child, while in adult population or older child, we need the curved blade. Also, when we are intubating a child below 20 kg, we need a shoulder roll. Beyond that, we put something below the occiput. This is very important. Most of the time, I've seen the patient are not using proper intubation technique. The cartilage and trachea are poorly developed, so the slight flexion or hyperextension can lead to the airway problems. Soft rib cage, so less chance of rib fractures. Small stomach capacity, so we have to be very careful while feeding the IG tube with IG tube, and they have high metabolic rate, so more chances of dehydration. So the oxygen requirement is 4 to 6 ml per kg per minute, while in adult it is 2 to 3 ml per kg per minute. Myocardium is also less compliant, less contractile. Most dysarrhythmias are less significant in pediatric population. Bradycardia is a terminal event, difficult to cannulate, so intraosseous is a better choice. This is very important. All age you can do intraosseous. Larger surface area, volume ratio, strict input-output chart is mandatory. Bones are flexible, so injury without fractures, as I discussed, are very common, and we need to have different equipments ready with the child. Injured child, they cannot escape from the seat sign. Large head size makes them more prone to head injury. Larynx is highly placed, as discussed. They have funnel-shaped airways, while tubular in case of the adult population. So liver is not covered by rib cage, hence more prone to damage. Small loss of blood makes them hypotensive early as compared to adults, because the higher the blood volume per kg, but less amount of blood. Hypothermia and hypoglycemia are more common in pediatric population, so we have to take care for these two common iatrogenic complications. So immature antibiotics, so you have to use immature immune system, so you have to use empirical antibiotics. Routinely, we approach a sick child, we take the history, do the examination, then we do the investigations and all that. This is not done in the acute care. Acute setting, all actions are taken parallel. So when you take the brief history, you make the immediate probable diagnosis, resuscitate the child, then make the probable diagnosis, resuscitate, intervene, reassess, then you go further. So this all actions are parallel in case of acute state, not in the series. So usually we follow the principle of direct when you are assessing a sick child or adult both. This principle applies to both. Direct stands for D stands for detection, I for intervention, R for assessment, E for effective communication, T for teamwork. Detection is usually done using primary survey. We follow the ABCD approach. In case of trauma patient, we follow SCABD approach. Scene safety and control of hemorrhage is very important. We do the sample physical examination, do some basic investigations, make what are the physiological and anatomical abnormalities during detection. We plan investigation accordingly. Then we intervene. You must know after intervention what is the end point of that intervention. Then you reassess. Communication between team member is important, and communication between where you have to talk to the other specialty also. So principle of direct is good to assess the sick child or sick adult. People have been using pediatric assessment triangle. That is also being used by some of the pediatric patients, pediatric doctors. But direct is the most important nowadays, because you don't have to remember for pediatric and adult except for the vitals parameter. Pediatric assessment triangle contains appearance, work of breathing, circulation to skin. Okay, there are three components which you are using. So normal respiratory rate is important to know, because children have high respiratory rate for the reason they have high oxygen requirement and low alveolar surface area. So when you are intubating a patient, you must know what is the normal. So up to 1 year, 30 to 60 breaths per minute is normal. We usually ventilate with a 30 rate per minute. Toddler 24 to 40, preschool 22 to 34, school age 18 to 30, and adolescent is just like adult. So lower respiratory rate, you just ventilate the patient. If the patient is having high respiratory rate, you can keep the rate when you're intubating, ventilating the patient 10% higher to avoid the asynchrony. But this is very important to know the breath rate in small child. Similarly, heart rate is very important to, because of the cardiac output basically in adult population depends on the stroke volume, while in the pediatric patients heart rate is important parameter for the cardiac output. So whenever you are making the physiological parameter, assessing the parameters, you should know what is normal. 140 is abnormal for the adult patients, but it may be normal for the newborn child up to 3 months of age. So this is very important to know. You should have a chart in your ICUs kept there for the normal physiological parameters. For newborn or infants, newborn on the basis of gestation age, we calculate the mean arterial pressure. So this formula tells you systolic blood pressure is usually taken as 50th percentile, but if less than 5th percentile, it is abnormal. So 90 plus age into 2 is 50th systolic blood pressure, 70 plus age into 2 is 5th percentile. So below that blood pressure after 1 year of age is taken as abnormal, signs of hypotension. Okay. So whenever you are monitoring the respiratory system, you should monitor the efforts, efficacy, and effects. There are 3 components. You should note the rate, work of breathing, respiratory sound, chest rise, oxygen saturation, 5 vital parameters, color of the baby. EtCO2 is nowadays is very common. ABG, heart rate, blood pressure, consciousness level, and ventilatory parameters. So whenever you are monitoring a child with respiratory system, following parameters have to be assessed to know whether the respiratory system is adequate, doing a good job, and the effects are all right. Similarly, for cardiovascular system, we monitor the pulse rate, pulse volume, capillary refill time. More than 3 seconds is always abnormal. Blood pressure, as I told you, if less than 5th percentile, it is abnormal. Level of consciousness, hypoperfusion can lead to decreased consciousness. Urine output less than 1 ml per kg per hour is abnormal. Pulse oximetry. CVP nowadays is because it is not a dynamic parameter, so we don't use much of CVP nowadays. SCVO2, echo is become more useful nowadays, and IVC collapsibility and ejection fraction, they have become more useful in today's time, and they are the just like stethoscope doing echo and IVC collapsibility. For nervous system, we measure the consciousness level, pupil size, and posture. For renal system, we monitor the input and output. Hourly urine output is very important. Blood urea, nitrogen, serum creatinine, serum sodium, potassium, calcium, magnesium, and phosphate level. Fluid and electrolytes. Fluid requirement depends upon the different weight with the different age and different age. Newborn, we calculate different fluid requirement in a different way. After 2 weeks of life, the requirement is usually 100 ml per kg per day. So children have more water content than compared to adults. So this is the table showing you the water distribution in the body of the human body with different age group. So for term baby, first day fluid is 60 to 80 ml per kg. Second day, we had 20 ml per kg extra. So that way, for preterm, we start with the 60 to 80 ml. And for preterm less than 1.5 kg, because of the larger body surface area, thin skin, the requirement is 20 ml extra. So 20 is added when the child is preterm less than 1.5 kg, or for term baby, it is 60 to 80 ml per kg, and we had 20 ml per kg extra per day. Normally, how to calculate the food requirement of the hospitalized child, active child is 100 ml per kg up to 10 kg. After that, we had 50 ml per kg per day, and more than 20 kg, we had 1500 ml plus 20 ml per kg per day. For critically ill but not intubated, the requirement goes down. Critically ill but intubated also, the requirement goes down because the respiratory loss is given by the humidifier, because we don't have the respiratory loss, it is already humidified oxygen is being given. So the requirement of the fluid is calculated on the basis of Holiday-Segar method. So we have to modify the fluid requirement depending on the disease condition. It is not a static requirement. If the child is ventilated, hyperventilating, or child is in high temperature, hypothermic, CHF, SIADH, renal failure. So all these conditions, we have to modify the fluid requirement. So you have to be very careful while calculating the fluid requirement in the pediatric patients, and you have to monitor every 6 hourly what is going on. Otherwise, we may end up fluid overload or under. So pre-operating fasting is same to adults for milk and solid. So milk, it is 4 hours. For clear fluid, it is 2 hours, and for again clear fluid, it is 2 hours. More than 36 months, milk and solid, it is 6 hours during when the child is going for the operative procedure. So these are the fasting guidelines. So you have to monitor the child on fluid therapy. For all these, monitor the liver size, heart rate, oxygen saturation. If there is signs of fluid overload, saturation will fall, respiratory rate will increase, mental status is also being monitored. Serum electrolytes, any child on the fluid electrolytes should have at least twice a day serum electrolytes measured. Weight record. So fluid monitoring is very important. Nowadays, we are giving higher fluid. Concept has come on a restricted fluid therapy. So calculate the drug on the basis of weight, check dose before delivery, monitor the side effect, toxic symptoms, modify drugs in renal and hepatic disease. So when you are ventilating the patient, what are the prerequisites? All required components should be present, functioning, and compatible. Components are assembled correctly. Electric supply is continuous. Entire system of gas is tight and free from occlusion. Operator is familiar to change the ventilator setting with patient clinical conditions. So these are the prerequisites. And you have to keep the ready endotracheal tube size, you have to calculate drug for rapid sequence intubation, setting the pressure, volume, modes, humidification, alarm setting should be kept 10% above the normal, and monitoring. So these are the things which you have to keep ready. If you are not good in intubations, you may use laryngeal mask airway, and you have to calculate on the basis, select the size on the basis of weight of the child. Okay, how to calculate the size of the ET tube is age divided by 4 plus 4 is usually taken as the for the uncuffed tube. But nowadays cuffed tube are being used for all ages. So 3.5 is taken as the standard. And whenever you are ventilating a patient, intubating the patient, you should keep one tube, one size above and one size below ready. So ventilatory tubing, appropriate size circuit is required depending upon the age of the child. There are 3 types of circuits available, 3 sizes. For infant, it is 10 millimeter, pediatric 15 millimeter, and for adult 22 millimeter in diameter. Disposable circuit has compliance of 2 to 3 ml per centimeter of water, and non-disposable circuit has lower compliance, also known as compressible volume. Nowadays, HMA filters are being used rather than using the humidified chamber. So ventilator system has 6 essential components: compressed oxygen and air supply, electrical and battery power supply, a ventilator, a breathing circuit, a artificial airway, and patient pulmonary system. So whenever these, it is important to know whenever there is malfunctioning, you have to check all the 6 systems. This is why this system is important to know. There can be electricity failure, can be oxygen failure, there can be problem in the tube, or in the artificial airway kinking, obstruction, or there can be increase in the resistance, or compliance is decreased. So this you have to know. So when you are setting a ventilator, switch on the ventilator. Most of the ventilator will ask patient weight in kilogram or pound, leak and tubal compensation, side breath, backup ventilator, back ventilation parameters extra are important. They will be displayed. Most of the current ventilator will blink light for setting up desired parameter once the mode of ventilation is selected. Check mode of ventilation associated parameter as per mode of ventilation, and you can use whatever mode, pressure or volume, for which you are comfortable. You can use any mode in pediatric population, and usually we start with the assist control mode, because nowadays control mechanical ventilation is out of practice almost, except when the patient is got neuroparalytic agents or patient of GBS or poliomyelitis you are intubating. So the FiO2 we try to keep less than 0.6. Okay, but initially we start with the 100% FiO2. Tidal volume is kept 6 to 8 ml per kg. PIP usually set is 15 to 20 as compared to adults, where the figures are same, because it depends on other parameters. PEEP usually keep 5 to 6 or 4 to 6 depending upon your choice. Ventilator rate you have to set infant 30, child 20, and adolescent 12 to 20 per minute. Inspiratory time you set 0.4 to 0.6 second in infant, 0.6 to 1 second in child, and 1 to 1.5 second adolescent. This is comparable to adult. Urine output, as I told you, is less than 1 ml per kg per hour is significant. Acute kidney injury you have to classify as like adults. Drug modification based on the creatinine level. If the creatinine level is more than 2 milligram per deciliter, we usually reduce the dose or increase the duration. Hemoglobin level is important to measure because of frequent sampling. Packed cells doses we have to calculate. Blood transfusion guidelines are similar to adults. There is no difference in pediatric and adult population. So this table shows you the what type of NG tube we are going to use, what is the size of Foley's catheter, what is the size of the chest tube required for acute care management. So key points are children are not mini adults. They depends for the care. Physiological parameters are important since they cannot verbalize. PET and pediatric early warning score are important to assess the children. These disease patterns are different. Respiratory failure is more common in pediatric population. Equipment for intubations are different in pediatric population. Ventilatory settings, as I told you, depends upon the respiratory rate, age of the child. So rest of the parameters are almost same. So the adult ventilator can be used in pediatric population. However, for neonatal population, you have different ventilators. Fluid and drugs are given on the basis of weight and not a fixed choice. Thank you.
Well, I would like to thank you, Dr. Kundan Mittal, for such an informative and scientific talk on pediatric ventilation. Now I would request our chairperson, Dr. Urvi Shukla, to introduce next speaker for thematic session. Ma'am, you are not audible.
We have with us Dr. Nirmal Choraria, who is a Chief Pediatric Intensivist, Director PICU at Nirmal Hospital Private Limited, Surat. He is the founder president of Perinatology from Surat, which was established in 1996. Dr. Choraria has been president of IMA and IIP and Surat Medical Consultants Association of the same city. In addition to his academic and professional achievements and contributions, he is a motivational speaker and he has delivered many lectures in Surat and South Gujarat on different topics. We welcome you, Dr. Choraria.
Recording in progress. At the outset, I would like to thank the organizers of World Conference on COVID and Critical Care. I'm going to speak on COVID in children, systemic manifestations. Childhood COVID-19 cases started early in the pandemic outbreak. Percentage of infections were lower in children. Children were rarely tested for the virus as they had no or only mild symptoms that did not require hospital admissions. However, it was later found that children and adolescents may also experience severe clinical symptoms and even an unfavorable outcome. We all know that children are less affected. ACE2 receptors are the functional receptors used by SARS coronavirus and SARS coronavirus 2 to enter the heart, intestine, kidney, and the endothelial and type 2 alveolar host cells through the viral spike protein. As the lung expression of ACE2 and transmembrane protease serine protease 2 progressively increases with age, it might be more difficult for SARS coronavirus 2 to enter the airway cells of young children and replicate. Trained immunity is a long-term programming of innate immune cells resulting from the administration of mandatory vaccinations or from frequent viral respiratory tract infection that might help to protect children against SARS coronavirus 2. Mandatory vaccinations provide cross protection by eliciting an enhanced immune response against other respiratory pathogens, including coronavirus 2. Children have a higher activation of interferon and higher level of helper and natural killer cells, which protects late complications of COVID-19. Healthier airways due to less outdoor travel, international journeys, less exposure to cigarette smoke and pollution. Age-related changes in the protein concentration of the coagulation system decrease the risk of thromboembolic and hemorrhagic events in neonates and children. The severity of the illness in children is less. 50% of the cases are either asymptomatic or having mild symptoms. Around 46% of the children develop moderate disease and 3 to 4% in total have severe or critical illness. After an average incubation period of 3 to 7 days, children may or may not develop symptoms. 4 to 40% of children found asymptomatic in various studies. Higher incidence in studies may be due to different enrollment criteria of students, study population, a large number of screening tests or contact tracing. The most prevalent symptoms were fever, cough, nasal symptoms, diarrhea, nausea, vomiting, and fatigue. The systemic manifestations mainly are respiratory system, the nasal symptoms like runny nose, nasal congestion, but loss of smell was less frequent than adults. Dyspnea and respiratory distress are closely associated with severe or critical manifestations. Lower respiratory tract infection was observed in the 25% of children, and ARDS in children was found to be rare, 5 to 8% cases. Next to respiratory manifestations are gastrointestinal. Up to 25% of cases may develop GI symptoms even without respiratory involvement, namely nausea, vomiting, diarrhea, and abdominal pain. Acute cholestasis, pancreatitis, and hepatitis have been reported in children and adolescents. Gastrointestinal bleeding is less noted. The cardiovascular symptoms are very, very rare, less than 0.15%, but they may manifest with heart failure, arrhythmias, myocarditis, pericarditis, cardiogenic shock, pulmonary embolism, myocardial infarction, etc. The neurological manifestations are encephalopathy, transient ischemic attack, stroke, central nervous system infection, demyelination, Guillain-Barré syndrome and its variants, acute fulminant cerebral edema, and psychosis. In a multi-center case of 1,695 children below 21 years hospitalized with documented SARS coronavirus infection, 36% had multi-system inflammatory syndrome in children, 22% had neurological involvement, which was transient in 88% of the cases. The cutaneous manifestations are maculopapular, urticarial, and vesicular eruptions, transient livedo reticularis, and acral peeling. The reddish purple nodules on the distal digits, sometimes called COVID toes, are described predominantly in children and young adults. Neonatal COVID, vertical transmission of SARS coronavirus 2 is thought to be rare, but suspected or probable vertical transmission has been described. A prospective cohort study from the United Kingdom of 66 neonates with SARS coronavirus 2 infection found that 3% may have had vertically acquired infection and 12% had suspected nosocomial acquired infection. The symptoms in neonates are fever, lethargy, rhinorrhea, cough, tachypnea, increased work of breathing, vomiting, diarrhea, and poor feeding. The critical disease in COVID-19 are because of ARDS, shock, encephalopathy, myocardial injury or heart failure, coagulation dysfunction, acute and kidney and liver injury. In presentation of the symptoms are respiratory in the critical children, about in 73% of the cases, and 50% had viral co-infection, radiological changes of pneumonia or ARDS, 24 to 30% of cases. ICU admission rate ranges from 3.5 to 8 to 19% in some studies. COVID-19 related death rate among children below 19 years was 0.17 per 1 lakh as of February 2021. The preferred test is RT-PCR, 94% sensitivity in naropharyngeal swab. Antigen tests are less sensitive, and may require follow-up testing, particularly negative antigen test results in children with symptoms compatible with COVID-19 or high-risk exposures. Factors associated with high risk of ICU admission: male gender, about 60% cases, pre-existing medical condition, immunosuppression, respiratory disorders, asthma, cardiovascular, congenital heart disease, metabolic and genetic disorder, sickle cell anemia, oncologic disorders, diabetes. Infants less than 3 months are more prone for ICU admissions. Baseline investigation in high-risk patients were complete blood count, differential count, C-reactive protein, glycosylated hemoglobin, kidney function test, liver function test, troponin I, thyroid function test, D-dimer, LDH, ferritin, blood group. Optional investigations are blood culture, CPK, interleukin-6, pro-BNP, dengue NS1 antigen. In India, according to the guidelines of management of COVID-19 in children, no investigations are needed in asymptomatic and mild cases. CBCSR, blood sugar, chest X-ray in moderate cases. CBCSR, blood glucose, CRP, liver function test, kidney function test, serum ferritin, D-dimer, and chest X-ray in severe cases. If the patients are admitted in ICU and they are critical, the repeat investigations are done like CBC, leukocyte count, absolute lymphocyte count, liver function test, blood urea nitrogen, creatinine, electrolytes, LDH. Every third day, CRP, D-dimer, ferritin, frequency and type of tests are decided by clinical condition and disease course. CRP is a surrogate marker of interleukin-6. Consider CT chest only if no improvement in respiratory status, not for diagnosis. Treatment. In mild cases, no COVID-19 specific medication, supportive medication like paracetamol for fever, adequate hydration. In moderate to severe cases, initiate immediate oxygen therapy, high flow nasal cannula, BiPAP, ventilator support, prone ventilation. Antiviral drug remdesivir has been approved by FDA. Corticosteroid and anticoagulants age indicated. Other modalities like interleukins-6 and 1 inhibitors, high-dose corticosteroid, IVIG, plasma exchange, absorption of cytokines by filter, ECMO, monoclonal antibody therapy are also tried in some of the critical cases. How to differentiate multisystem inflammatory syndrome with acute COVID? Compared with patients with COVID-19, patients diagnosed with multisystem inflammatory syndrome in children were more likely to be 6 to 12 years old and have no underlying condition. Patients with MISC were more likely to have cardiorespiratory involvement, cardiorespiratory without respiratory involvement, and mucocutaneous without cardiorespiratory involvement. Patients with COVID-19 were more likely to have underlying conditions and respiratory, neurological, or gastrointestinal involvement without cardiovascular or mucocutaneous involvement. Patients with respiratory and gastrointestinal involvement are more likely to be RT-PCR positive, while patients with cardiovascular mucocutaneous involvement showed more antibody positivity. In patients with MISC, 34.2% had depressed left ventricular ejection fraction and 13.4% had coronary aneurysm. Fewer patients with COVID-19 underwent echocardiography assessment. Depressed ejection fraction and coronary aneurysms were infrequent in those evaluated. Patients with an neutrophil lymphocyte ratio greater than 5, platelet count less than 1.5 lakh, and CRP level greater than 100 milligram per liter within 48 hours of admission were more likely to be diagnosed with multisystem inflammatory syndrome in children. Few studies describe the long-term outcomes for children with COVID-19, and the risk of persistent or recurrent symptoms is unclear. Commonly reported persistent symptoms include fatigue, headache, sleep disturbance, muscle and joint pain, respiratory problems, palpitation, and altered sense of smell and taste. Few children may develop multisystem inflammatory syndrome in children after 2 to 6 weeks. Ongoing follow-up of children with COVID-19 is necessary to better define the long-term outcome. In summary, I would like to mention that SARS coronavirus 2 infection is generally milder in children compared to adults. There are limited data on the pathogenesis and clinical spectrum of COVID-19 in children. Respiratory and GI manifestations are predominant in acute COVID-19 infection in children. Most children with mild or moderate disease can be managed with supportive care alone and will not require any specific therapy, specific treatment in moderate and severe cases as per the guidelines. Thank you. Thank you very much.
Thank you, sir. I would like to thank Dr. Nirmal for such an informative talk on COVID in pediatrics. I would like to thank all the speakers for such a knowledgeable, wonderful, and scientific informative talk. And also would like to thank all the chairpersons for the valuable time. And now coming to this end of second thematic session and moving forward to international session. Now I hand over the mic to Dr. Ankita for further proceeding.
Good afternoon, everyone. Moving forward for the next session. The next session for the day is the international session. And to chair this session, I welcome Dr. Shubhranshu, allergy, asthma, and pulmonologist from Jaipur. Dr. T. Shyamasundar, Medical Director, Thambe Hospital, Hyderabad. Dr. Prerna Chandra, Assistant Professor, Department of Anatomy, State Medical College, Agra. And Dr. Neeraj Basantani, Chief Consultant Neurosurgeon and Stroke Interventionalist, Shanti Ved Institute of Medical Sciences, Agra. I would now request Dr. Shubhranshu to introduce our first speaker. Dr. Shubhranshu.
If Shubhranshu is not here, can another one
Dr. T.
introduce him?
May I request Dr. T. Shyamasundar to introduce our first speaker?
Can another introduce him?
Dr. Prerna Chandra. May I request Dr. Prerna Chandra ma'am to introduce?
Dr. Prerna Chandra is not here. Dr. T. Shyamasundar is here, and Dr. Neeraj is here. Either of them can introduce two speakers each.
Okay.
Hello. Can you hear me?
Yes, you are audible.
So I would like to introduce our first speaker for the day, Dr. Quirino Passivovelli. He is the professor and head Department of Anesthesia and Intensive Care, San Filippo Neri Hospital, Italy. And he has been the president, World Society of Intravenous Anesthesia and president, Society of Clinical Risk Management, Italy. I welcome you, sir.
Hello, good evening. Thank you for this kind invitation. Great opportunity for me to take part in this important Congress. I would like to thank all the scientific committee for this invitation and of course my friend Dr. Rund. So I start to talk about what went wrong in Europe and especially in Italy in managing COVID-19 and what is important to find the right way forward. In the recent months, since the beginning of the pandemic, we have witnessed numerous debates on this issue with a very often divergent, if not conflicting conclusion, with opinions with scientific content and many others with a naive flavor. All this pseudo-intellectual scientific cacophony, one thing made us understand. that the pandemic has made us change our way of life. Many things will never be the same again. And while we are living a liberating moment from this nightmare in some Western countries, we are unaware that the virus continues to wipe out thousands of lives in countries close to us, such as Russia, Great Britain, not to mention India, Pakistan, Bangladesh, Malaysia, the Philippines, Indonesia, Japan, USA, and Brazil. I would like to recall what the Secretary of the United Nations, Antonio Guterres, said recently in this regard during the G20 conference in Rome on the Global Health Summit. Nobody can be considered safe until everyone is safe. Groups of independent scientists to wonder what mistakes have been made and if all this could have been avoided, and finally how to prepare for the future so that this drama does not repeat itself. The first conclusion was that this disaster was entirely foreseeable. The initial outbreak in Italy, but not only became a pandemic as a result of gaps, failure in every critical moment of COVID-19 preparedness and response. Years of alarms of an inevitable pandemic threat have not been addressed, and there have been inadequate funding, inadequate preparedness stress tests, despite the increasing rate of which zoonotic diseases are emerging. Precious time has been lost. Too many countries, including Italy, have adopted a wait-and-see approach rather than an aggressive containment strategy that could have prevented the global pandemic. Countries like Italy in the beginning, with delayed responses, have also been characterized by lack of coordination, inconsistent or not existent strategies, and the devaluation of science in guiding decision-making. The devastating reality of the COVID-19 pandemic has shown how an infectious disease can sweep the global in weeks and within months delay sustainable development for years. The data, despite their lack of occurrence, give us knowledge of what happened. I just show you some number of cases from 2020 to September the 1st, 2021, confirmed by the test are more than 4,500,000. And the rate positive and tested persons is very high, 8.8. Number of hospitalized cases in the same period is more than 255,000. And in intensive care units, in the same period, we have more than 43,000 patients. Number of deaths due to COVID-19 during the same period, we have more than 130,000 deaths. Number of healthcare professionals, other than doctors, infected, confirmed by the test in the same period are more than 136,000. Number of healthcare professionals deceased by COVID-19 in the same period were 87. The number of doctors infected confirmed by test in the same period for salaried doctors are more than 3,748. The number of doctors deceased by COVID-19 as salaried doctors in activity, 131. Community-free practice doctor in activity, about 49. Family doctors, 109. Retired doctors, 71. In this moment, the restriction in my country are very, very few, and there is an approach to liberalize all the activity. The last one about theater and cinema. If an hospital organization faces the COVID-19 situation was required, it concerned mainly public hospital and not private hospital. The COVID-19 antibody test is mandatory for all healthcare professionals. The COVID-19 is considered now in Italy an occupational disease for healthcare professionals. We have, of course, changed the protocols during this time to treat COVID-19. For example, we don't use anymore hydroxychloroquine, remdesivir, lopinavir, ritonavir. But we are now using new drugs like mononuclear antibodies, interleukin-6 receptor blockers like tocilizumab or sarilumab. The occupancy rates in the hospital now at September 1st, 2021 in ICU is 7.8. This occupancy is related only on the real number of 7,500 beds compared to the official declared. In the wards, we have 90% of occupancy, and in usual care units, 10% of patients with COVID-19. The vaccination in Italy is not compulsory. The percentage of the first dose of the general population is around 73%, and the second dose vaccination is around 65%. The vaccination is compulsory for healthcare professionals. And the percentage for the first dose is 95%, and for both of the dosage, 73%. We are starting to make the third dose a booster vaccine, and is only for over 70 years old. There is a persistent impact of GDP, yes, of course, and also for the unemployment. In other words, pandemic preparedness planning is a key function for governments and the international system, and must be supervised at the highest level. Is not the responsibility only of the health sector. At the beginning of the spread of the virus, the COVID-19 epidemic in Italy was not considered an health emergency. The first warning signs were greeted with skepticism by both public opinion and many politicians, even though many scientists had claimed for weeks that there was a risk of a catastrophe, thus creating a dangerous confirmation bias in public opinion, namely the tendency to focus on information which reinforce our initial opinion and assumption. The second lesson to be drawn from the Italian experience concerns the importance of adopting a systematic approach and the dangers of a partial solution. The latter have led, for example, to an increase of mortality, not only in full COVID-19 included, but also for other diseases that have been neglected due to the pandemic. Another effect, that effects of which will be felt for months, is that of having had to postpone hundreds of thousands not urgent intervention. The recent study that have discovered that COVID-19 is a disease that can have important consequences deserve a chapter in itself. When we talk about post-COVID syndrome, we refer to the persistence of more or less debilitating symptoms after the acute phase of the disease and the negativation of a virological test. 30-40 of positive COVID patients have symptoms and sequelae for many months after recovery. In addition to fatigue, breathing difficulties, heart and memory problems, new symptoms may also develop, never seen before of a disease, such as emotional lability, mood disorder, anxiety and insomnia, dermatitis, and many others. The virus persists for a long time in the stool, even if it is no longer detected by nasal swabs, and until the intestinal bacterial balance is restored. You may be subject to lack of appetite, weight loss, and sense of exhaustion. It is also important to manage the mental disorder of these patients, many of whom have a post-traumatic stress disorder. Dear colleagues, thank you for your attention. Dear colleagues, it's a great
Thank you, sir, for sharing your experience with us. Now, may I request Dr. T. Shyamasundar to introduce our next speaker. May I request Dr. Neeraj to please introduce us? Ji, sir.
Yeah, may I introduce Dr. Professor Mitchell O'Leary. He's a senior specialist in intensive care in Sydney, working at Alfred Hospital and at St. George Private Hospital. He's a clinical associate professor at Sydney Medical College, University of Sydney, and co-state medical director of New South Wales Organ and Tissue Donation Services. Hello.
Rishabh?
Hello.
Yes, please.
Hello, my name's Michael O'Leary, and I'm a staff specialist in intensive care at the Royal Prince Alfred Hospital in Sydney. And I've been asked to give you a talk on the Australian experience in managing the COVID pandemic. Now, as most of you will probably have heard, Australia, well, certainly until the middle of this year, has been feted internationally as perhaps one of the gold standard countries for the management of the pandemic, because we've seen relatively few cases and had relatively few deaths in comparison to other countries. So this slide shows our experience over the first year of the pandemic. The first case in Australia was reported on the 25th of January, and the government moved fairly quickly to ban travellers from mainland China from entering the country on the 1st of February. Nonetheless, we were up to 100 cases by the 10th of March. And I think that at about that time, those of us who work in healthcare believed that we were on the cusp of experiencing the same that we were hearing from northern Italy and elsewhere. But the big advantage that we have in Australia is that we're an island, and the vast majority of entrants come by air. So on the 16th of March, the government announced that all arrivals would have to enter 14 days of self-isolation. And 4 days later, the government essentially closed the border to all arrivals. Moreover, the government announced a ban on Australian citizens leaving the country. And I think that Australia is the only country in the world that imposed such a measure in response to the pandemic. And as with most other countries in the world, we entered a lockdown from the 23rd of March. So as you can see, these initiatives seem to have been fairly effective. In fact, cases peaked at the beginning of April at just under 400 per day, with about 50 deaths. Most cases actually were in returned travellers, and most in New South Wales, and there was relatively little community transmission in Australia in this first wave. So most of the lockdown restrictions were lifted by the middle of May. Unfortunately, in early June, there was an escape of virus from the hotel quarantine system for returned travellers in Melbourne into the community, and this caused a significant second wave in Melbourne. This was met by a heavy lockdown by the Victorian government, and even this wave, however, peaked at only about 600 cases a day, although there were 820 deaths. Amazingly, this lockdown was very effective, and by October, community transmission of the virus had been eliminated in Melbourne. So to summarize COVID in the first year in Australia, it was essentially a disease of the elderly and a disease in Victoria. So here you'll see that the second wave was essentially entirely in Melbourne. Deaths were heavily skewed to the aged care population. Here, 10% of cases were in aged care residents, but they accounted for 80% of the deaths, a case fatality rate of 32% compared to only 0.8% for non-aged care residents. So by the later stages of 2020, I think many of us felt that Australia had dodged the COVID bullet. There were a few isolated outbreaks, but these were always brought under control by test, trace, and isolate programs or by lockdowns. And by March of this year, we were essentially pretty much back to normal life across Australia, except for the very strict international entry and exit bans, which were maintained. I think that, unfortunately, our success led to a bit of complacency as the onset of vaccination was somewhat later in Australia than in Europe or North America, but more on that shortly. In early June, there was a leak of virus from an international arrival into the community in Sydney. Despite a lockdown from the 28th of June, the outbreak then spread to Victoria in early July. The strategy this time was to chase the outbreak with vaccination. As I made this slide, this seems to have been quite successful. In New South Wales, cases peaked at about 1,600 in early September, and we exited lockdown on the 11th of October. Victoria is still experiencing quite high caseloads, around 1,500 to 2,000 a day, but seems to have stabilized. This time, the disease demographic is much different, probably due to the fact that early vaccination was being directed to the more vulnerable populations, including aged care. Of the 90,000 odd cases reported to the 8th of October, 5% were in aged care residents. And although these cases were still associated with a higher mortality, this nowhere approached the levels that we'd seen in the first and second waves. So how has the pandemic affected us in intensive care? Well, during the first wave, to be honest, there was very little impact. This graph shows ICU bed occupancy by COVID positive patients in hospitals that reported at least one case. And as you can see in the first wave, at worst, this was around 12% of beds. Even in Victoria, in their second wave, on the worst days, they were only having COVID patients occupying about 20% of ICU beds. In this third wave, however, the graph I think is a bit misleading, as the major teaching hospitals in New South Wales by mid-September were facing 100% or more bed occupancy once non-COVID patient loads were also considered. Briefly on treatments and outcomes, here comparing the three waves, you'll see that there was much more use of high flow nasal oxygen and non-invasive ventilation in the later waves, less mechanical ventilation, and more prone positioning in the current wave. Obviously, steroid use is now very high in comparison to the first wave, and there's also more use of antiviral drugs. Overall, ECMO appears to have been relatively rarely required. We do seem to have reasonably respectable ICU mortality outcomes thus far, although I do caution that in this current wave, you'll see that 50 to 70% of cases have yet to have a final outcome determination, so the mortalities may be greater in the end. But overall, for ventilated cases in the ICU, we've been seeing a hospital mortality of around 20%. ANZICS, our Intensive Care Professional Society, has very much been on the front foot in responding to the pandemic. A first version of guidelines were published on the 16th of March, covering a wide range of important issues to guide response and planning, as you'll see here. The Society worked closely with the Commonwealth Government to develop this website where ICUs enter real-time data on ICU bed availability and occupancy. On this website, it's possible to see real-time national and state-based data for your own state individual hospital data. And I know this has been particularly useful in New South Wales during the current wave to facilitate the distribution of COVID patients between ICUs to avoid individual hospitals being overburdened. The website also collects information on staff availability, PPE availability and equipment, and recently also the vaccination status of COVID positive patients admitted to the ICU. It also allows one to generate quite impressive graphs of activity statewide and on an individual hospital level. ANZICS has partnered with a number of other professional societies in the National COVID-19 Clinical Evidence Task Force, and this group has produced an impressive array of guidelines, flowcharts, and evidence synthesis, and it's all freely available on the website. Okay, so I've mentioned that Australia was really quite late to start our vaccination program compared to many other countries. Here you'll see on this graph that compared with the UK, Israel, and the US, for example, we were more than 2 months later in starting vaccination. I'm going to discuss this a bit more in the next slide, but just to point out the one other thing this graph shows is that right now, Australia and India are the only 2 countries of this group where the number of vaccine doses administered is still increasing. So back in March, responding to concerns about how slow the vaccine rollout was going, our Prime Minister, Scott Morrison, told us not to worry. It's not a race, he said. I think the combination of poor vaccine availability and concern of risk after the scare of VITT with the AZ vaccine added to the fact that there was essentially no COVID transmission occurring within the community, meant that there was no urgency in most of the population to bother getting a vaccine. So at the time of the Sydney outbreak in June, where the arrow is, less than 25% of the population had received 1 dose of vaccine. One could say then that the Sydney outbreak was the outbreak that we had to have, as since then, vaccine progress has been impressive, especially in New South Wales, Victoria, and the ACT. On the 8th of October in New South Wales, we had 90% of the adult population with at least 1 dose and over 70% fully vaccinated. And we already have well over 60% of our 12 to 15-year-olds with at least one dose of vaccine. So to finish up, some personal reflections on where we are now after this tumultuous 20 months. Well, we finally seem to have got the vaccine rollout right, but to me the challenge is whether we now start again with boosters or third doses, especially for those of us who got our vaccine at the beginning of the campaign, or whether we can defer that and concentrate on sharing our vaccine doses that we have left with more needy populations elsewhere in the world. The consequences of slipping backwards at home for me are so profound that I find it's a very difficult question. Then there's the impact of new therapies in COVID and whether they are going to make any real difference to the ICU burden of the disease. Very important, however, I feel, is that as a society, we look closely at the impact of the public health measures. I feel that there's been far too little attention paid to the negative impacts of these measures. And I feel that we really do need to have a much higher bar before we again think of embarking on lockdowns and business closures in response to a public health crisis. A lot of this, I think, is linked to a significant change in societal view about death and dying, and a view now that all lives can potentially be saved. If someone dies, it's someone's fault, and cost is immaterial. What is the value of a life? Scott Morrison, early on, when asked how he could justify destroying the Australian economy for mainly aged care residents, he looked fiercely into the camera and said, every Australian life is worth protecting. Well, people die of all sorts of preventable things, and we don't worry too much about that, it seems to me. So why was COVID so important? I'll leave you with that question. Thanks very much.
Thank you, sir, for this wonderful experience that you shared with us. Now, may I request Dr. Neeraj Basantani to introduce our next speaker?
I welcome Dr. Buddhini Embulpitia. She is consultant intensivist from Sri Lanka. I welcome you, ma'am, for your talk.
Good afternoon, everyone. I'm Buddhini Embulpitia. I'm an intensivist from Sri Lanka. Myself and Dr. Lilanthi Supasinghe, we got prepared to talk to you today about the Sri Lankan experience in COVID pandemic. We are very thankful to the organizing committee in World Conference on COVID and Critical Care 2021 for inviting us to talk to you all today about Sri Lankan experience in COVID pandemic. My speech is outlined on preparation, timeline, statistics, response and guidance from the hospital in managing the pandemic, our therapeutic interventions in practice, current infection containment and vaccination strategy, and recommendations. So in preparing for the outbreak, we planned at preventive, curative, and allied health levels, at national as well as at regional levels. So the course of the preparation included imposing quarantine process, travel restrictions, lockdowns, and formulating treatment guidelines, including adult, pediatric, obstetric COVID-19 management. And we have mobilized resources from preventive to curative sectors and improving healthcare level facilities for critically ill COVID patients and integrating home care management system for a selected cohort of patients and expediting program for vaccination as well as promoting scientific research. So our country got ready for a new normalcy, having guidelines for workplace safety, and we have implemented remote education for schools and universities and mass health education. New facilities for improving PCR testing were implemented and laboratory diagnostic techniques defined and streamlined. Stakeholders in preparation was mainly leadership was taken over by the Ministry of Health, along with the Epidemiology Unit, Health Education Bureau, Family Health Bureau, and specialist colleges. Not to mention the special work done by our task forces, National Operations Center for Prevention of COVID-19 Outbreak, comprising of Army, Navy, and Air Force. Other than the government organizations, the non-governmental organizations have done a great deal in managing this pandemic. When we talk about the current incidents, we have had 533,208 confirmed cases and 13,543 deaths up to now. During the last 24 hours, we had 548 new cases and 18 deaths. So when we talk about the epidemiology, we have had 3 waves, and the last one, third wave, was the worst. Our first wave was from early 2020 to October 2020, and it had only 3,000 plus cases. Second wave was from October 2020 to April this year. It had 92,000 plus cases. Worst was the last one from April this year up to now. We have had more than 422,000 cases and more than 12,000 deaths, and we had a high case fatality rate of 2.9. And when we talk about the age distribution, mainly the 30 to 60-year age group was affected most, and males were affected more than females. But by the last wave, it was getting more equal still with the male predominance. This is how the death trend has occurred. It peaked somewhere in mid-August and early September, but now it is coming to an descending trend. So when we consider the confirmed deaths and their comorbidities, diabetes and hypertension is seen in most of the patients who died with comorbidities. So hospital preparedness, we had task forces in every hospital. We prepared an operational cell for COVID management, and we have strengthened the outpatient department and emergency department. Triaging systems were well established. Designated interim COVID suspected wards and COVID confirmed wards were established, and critical care facilities were improved for COVID as well as non-COVID patients. Safe transfer of patients to designated hospitals were implemented, and safety of the healthcare staff who are managing these patients was also ensured, enabling adequate supply of personal protective equipments. And we had separate designated hospitals for management of pregnant patients with COVID-19. And with the nature of the epicurve, the guidelines needed to be updated, and we had to prepare hospitals for exit strategies as well. So during this pandemic, our country increased the oxygen production capacity to a maximum of 80 tons per day. And we have also increased the bed strength over time. Intensive care units have increased their bed capacity. Wards as well as high dependence units were newly established with wall oxygen facility. And we have purchased ventilators, NIV and high flow nasal oxygen machines, as well as through donations, and increased our facility for critically ill patients who need oxygen and non-invasive and ventilatory support. We have also trained ICU doctors and nurses to manage these patients. And the ministry is identifying centers for ECMO facility with the COVID pandemic. And currently, Teaching Hospital Karapetiya has a very well-established ECMO facility. So the current therapeutic interventions in practice, we give oxygen to these patients who need, who has a saturation less than 94 on air. And we provide dexamethasone 6 milligram daily for 10 days as per recovery trial for patients who are on oxygen. Anticoagulation is given to patients depending on their organ support and D-dimer level, CTPA results. Antibiotics and antifungals are also given whenever indicated. Biologic therapy is considered early. Antiviral therapy is also considered early wherever it is available. And depending on the expertise, in some centers, they practice giving steroids for patients who are dependent on long-term oxygen and patients who have HRCT evidence of organizing pneumonia. Antifibrotic therapy is also considered for post-COVID ILD patients. And those who are dependent on oxygen, even after 2-3 months, and when we reduce the level for about 5 liters, we send them home on oxygen concentrators. And the number of complications and post-COVID syndromes are rising. And the number of patients with post-COVID ILD is also rising. So we are establishing new clinics to manage these patients and for their rehabilitation. So current infection containment and vaccination strategy in our country included island-wide lockdown in the last wave because we had a very high number of cases and deaths, which was stopped only on 30th of September, and it has affected the number of cases coming up. And now we have a very few cases compared to the initial, compared to August. At the moment, we have a few number of cases. And the travel restrictions are still in place, overseas as well as in between provinces. And when we talk about the vaccination, we started vaccination in late January 2021, and 5 types of vaccines are approved in our country: AstraZeneca, Covishield, Sinopharm, Sputnik, Pfizer, and Moderna vaccines. And this is how the number of vaccines are being given in the 5 categories. And I'm very happy to say by this time, nearly 60% of the total population is vaccinated with both doses. And when we consider the age above 18 years, the eligible population, 95% of them have received the first dose, 82 both doses. So there is an important thing about home-based management when we are discussing about managing COVID-19 patients. So we are implementing home-based management in asymptomatic and mildly symptomatic low-risk patients, and these patients are managed by a designated group of medical officers, assisted by the curative sector, by triaging and significantly reduce the burden on overfilling hospitals. And non-profit organizations have also helped in managing these patients. So we recommend proper and timely planning in managing a pandemic. And we also recommend revising protocols and updating them depending on the dynamic nature of the pandemic, involving all stakeholders representing health, planning, economy, education, and administration and policy making, and to collect and analyze scientific data with regard to the disease pathology, therapeutics, and vaccination. All regions to have an efficient vaccination program prioritizing the high-risk groups and covering the whole eligible population in a stepwise manner. And to take community vaccination effective and to establish integrated home-based system as we discussed for asymptomatic and mildly symptomatic patients, and to ensure the safety of healthcare workers, including their immediate families, and also to implement a national COVID health information system. So I take the opportunity to thank my colleagues. These are ICU staff in National Hospital Colombo, Kotalawala Defense University Hospital, our ECMO treatment group from Karapiti Hospital, and some from Kandy National Hospital, who have worked tirelessly during these last 3 to 4 months to save patients. Thank you very much for listening to me.
Thank you so much, ma'am, for sharing your wonderful experience. Let me ask Dr. T. Shamasundar to introduce our next speaker, please.
Hello. Hello.
Hello. Hello.
Can I share the video?
Hello.
Hello. Can I share the video?
Dr. Shyam Sundar is not introducing.
Who will introduce?
Dr. Shyam Sundar? Dr. Shyam Sundar, am I audible?
Prashant sir is not here. I think
No, he is here. He is here.
he's here.
Yes, yes, he is.
Dr. Shyam Sundar. Dr. T. Shyam Sundar. Can you please introduce Dr. Prashant? Hello, Dr. Shyam Sundar. Hello.
Is Dr. Neeraj here? Dr. Neeraj is also
Dr.
not here.
Neeraj.
Dr. Prabhat, can you please introduce Dr. Prashant Nasa?
Hello.
Introducing our next speaker, Dr. Prashant Nasa. He's the head critical care medicine, NMC Specialty Hospital, Dubai. And he is heading the infection control department of the NMC Specialty Hospital, Dubai. Sir, please continue with your talk, sir.
Thank you, Dr. Ruta and organizing committee to allow me to be part of this World Conference on COVID and critical care. So I will be talking about our experience from the first wave, second wave, and what we are doing to, to work on the future waves if they will be coming to us. So we know the waves of cases in UAE were not very simple like what happened in India. So they were not just two straightforward waves. So we had few ups and peaks, which were a little different from the two classic waves which we saw in India from the confirmed cases. So how we started, we started few weeks back, or rather I said a month or more back, when we started getting news from China that there was number of cases which were rapidly increasing and WHO declared pandemic. So somewhere in March, where we received the first case. So before that, we actually start preparing up, and that preparation was basically to start with the team meetings. So, and we involved the key stakeholders, we prepared for the contingency plan. So this was some sort of situation which was there before COVID-19, when we were getting patients, we were following the open visiting policy, followed by a sudden change in shift in our ICU, and the patients were living or staying alone in the ICU, and we were covered up with multiple layer of clothes. Why ICU were very important for COVID-19 from the start of the pandemic. We were aware that the many patients require ICU admission, and there were certain requirement of the beds which we saw from China and the other part of the world where the patients started coming up a little earlier than us. So for us, the patient number started increasing very rapidly by the March end. It was very much important when the number of beds are already very limited in terms of intensive care units. So we had almost at that time 15 beds for our intensive care unit in our hospital, which is 110 bedded. By March, we started increasing our capacity by 10%, and then later on to surge, we increased it up to 25%. And different areas across the world, we know that number of ICU admission increases as the number patient during the surge, and that was also directly related to the mortality. Vice permission age was independent respect of mortality across the world. And that what very similar happened for India also. So there was a lot of patients which were, they are coming up in the second wave, but the information before the second wave, during the first wave, because of the the lockdown policy by the government, that helped in spread up of the cases rather than getting a sudden peak. There was spread, and there was a staggering surge which happened in India, while in the second wave, which was, I think, where little laxity in the rules and complacency among the public led to a little delay of recognition, and that led to a very sharp rise in second wave. May also be labeled due to the new variants which were coming up from the wild one variant, which was responsible for first wave. So there are some information available now that the second wave was in India, just not just because of complacency or the people were not enough exposed, but also because of the change in the pattern of the virus itself. But there was many more information which was now available in the public why what happened in the second wave. So I will not be going into that part, but we know that ICU bed capacity is something which is where India really lags behind from across the world. But for us being living into a very high nation with a much more available resources, the ICU beds were good enough, so we never had such problems. But the problem was basically the number of airborne infection isolation room, which was much more required in intensive care units. So it was not just the bed, but also the beds which are able to handle COVID patients. So that what was issue, and that what was recommended by different healthcare agencies. So building infrastructure was very much important, and availability of the staff was followed by another issue. Besides that, there were issues about the modifications which we need to do for healthcare for healthcare worker protection. So there were a lot of things which were recommended, and now what we know that there has been enough research to say that these intubation boxes or these modifications do not add any further layer of protection, but in fact complicate the procedure itself. So it's no more valuable to add up these things unless there is enough training and enough resources which have been utilized to prevent the healthcare workers to get exposed. So these modifications were done and are still being done at some places, but over a period of time, what we have learned is stick to the basics, but also besides the basics, it's also important to save your healthcare worker from the exposure, and that what is a real resource at the time of these surge. There were some recommendations which really helped, like use of a video laryngoscope, and that has become now a standard of care into intensive care units for intubation with or without COVID-19. And enough preparation. So that what we should be doing for not just COVID patient, but also other patients into intensive care unit. But this pandemic itself, put a lot of focus into preparation during intubation, and most of the exposure what our healthcare workers have seen is only during this aerosogenetic procedure. So the preparation, which along with enough PP and educate PP, is something which is very much important. So team briefing, avoid crash situation, avoid back ventilation, and use of end-tidal carbon dioxide during intubation and post-intubation is something which has become now an integral part of our intensive care unit, especially during intubation and the initial start of ventilation. There were a lot of focus about how to use appropriate PP, and that what was recommended, and then these modifications do come up using combination of devices and other things. But and these so-called sharing of the ventilators do come up, but they have enough now data to not to use these notifications as what has been tried in the initial phase of the pandemic. And then we had to prepare ourselves for something known as overwhelming. So this has never been a part of our resource or part of our training, but now because of this at least 2 waves with sudden surge of cases, overwhelming of resources, overwhelming of healthcare setup, this has become an integral part of our critical care management. And I think there is a lot of planning which is happening at different units and has happened and probably will be happening again in the future pandemics. So this is what is critical triage, which is very much important, whether triage of resources, triage of human power, or triage of patients which are required. Then there are enough data which started coming up, for the things like awake proning, which was recommended for many patients in intensive care unit or out of intensive care unit to try to worsening of the hypoxemia. But now information is there now enough to say that these things do not change the outcome. The patient may help only to improve oxygenation to buy some time. So awake proning should be considered, but not at the expense of delaying intubation, that what has been recommended. Again, we now know that, in the start of the pandemic, there were few off-label drugs which were brought to our either hospital setup or intensive care units with very, very limited data, but much more of a political hype. And that what has happened to, unfortunately, to hydroxychloroquine. With a lot of political hype, this product was actually fanfare in the first wave of pandemic, and most of the patients received, and not just the patient, but also healthcare worker do receive this off-label medication in terms of, in context of either prophylaxis or other things. But later on turned out to be again a fluke as the evidence started emerging. And the same vein, I should talk about these two major randomized controlled trials, or other two major societies or two major groups, which produced a lot of evidence, and has changed the way we have to do research probably in the future. So these rapid, adaptive trials, which brought a lot of evidence on, therapeutics in management of COVID-19, has been more of focus of this pandemic, and has actually been a success story of the pandemic. And again, this tele ICU, or more of a digital or digitalization of the ICU, or remote monitoring of the ICU, has brought much more focus through the COVID, because to avoid either healthcare exposure, or to during the surge may need to monitor much more number of patients. What has also been put up into focus during these waves have actually been abuse of antibiotics. We know that co-infection rate with COVID-19 is far less as compared to what we know about an influenza or other viral respiratory viral infections. But despite that, there has been very high rate of secondary use of antibiotics on the context of experience from the previous viral pandemics. So there is much more abuse, and that's what we need to stop and need to consider now, probably in the future. And we need to protect our healthcare worker, which are I think the most valuable resource we have understood out of this pandemic. So it's important that they should not be given just physical protection in terms of either PP, but also in terms of either mental and social protection, which is very much required for preparation of these resources, for preparation of our healthcare worker for the future waves. So it's important that we should protect our healthcare workers, both by using physical means like enough personal protective equipment, but also by using them enough training, or preparing them with enough training, and also availability of other infection control measures. So it's important to do a staff welfare briefing sessions using different other resources like psychological or social networking, but also to involve them into many other information like communication updates, and developing a team buddy. So it's communication which really need to be updated and need to be revised while preparing for the future pandemics. So that's what we will be considering. Going forward, we know that I think the vaccination has been a success story, probably, which will be deciding the future course of the pandemic. And that what has led United Arab Emirates to fully vaccinated of almost around 85% of their resident population, and 95% has received at least one dose of vaccination, followed by many other countries. And India is really catching up and rapidly catching up, with almost 50% of the population has already received the first dose of the vaccine, with 20 to 30%, 20 to 25% have received fully vaccination. So this data has been captured from our World website, which has up to 18 November. I think that what will be the message for the future. So teamwork is a key to crisis, and that's what we have learned into last these waves. I thank you again, organizers, for giving me this opportunity.
Thank you, sir. I would like to thank all the esteemed chairpersons and speakers for a wonderful and knowledgeable session. Let's move forward to the next session of the day, which is the oral paper presentation. And I would be pleased to welcome our chairperson. Our first chairperson is Dr. Manoj Singh, Critical Care Specialist from Apollo Hospital International Limited, Ahmedabad. Our next chairperson would be Dr. Geeta Karki, Professor from Department of Anesthesiology, SRMS, IMS, Bareilly. Our third chairperson would be Dr. Vimal Bhardwaj, Consultant Intensivist, Mazumdar Shaw Medical Center, Narayana Hridayalaya, Bangalore. And our next chairperson would be Dr. Saurabh Kore, Senior Cardiologist, Chairman, Critical Care Society from West Bengal. May I request Dr. Manoj Singh to introduce our first speaker.
Yeah, I think if we are on the track, I think the first speaker will be so may I invite Dr. Kavya Sindhu to present the talk, which is correlation of the central venous to arterial carbon dioxide difference to arterial central venous difference to the lactate clearance and prognosis in septic shock. So Dr. Kavya Sindhu, over to you.
Sindhu, I am from Dr. RML Institute, Lucknow. The present study, what today I am going to present about, to evaluate central venous to arterial carbon dioxide difference and arterial to central venous oxygen difference ratio with lactate clearance in patients with septic shock. It's an observational prospective study. We all know sepsis is a life-threatening organ dysfunction caused by dysregulated host response to infection, and septic shock is a subset of sepsis which requires vasopressors and inotropes to maintain MAP more than 65 mmHg and serum lactate more than 2 millimoles per liter despite adequate fluid resuscitation. In addition to it, we know about the sepsis surviving sepsis campaign bundle, which we want to take the lactate also at the baseline level. And even though there are so many markers, sometimes if there is central venous oxygen saturation more than 70%, it might show. As I discussed in this slide, even though sometimes if central venous oxygen saturation is more than 70%, the central venous to arterial CO2 is a proposed tool to identify persistent hypoperfusion. Means as oxygen is more than 70% saturation, we thought it is normal. Now, if there is some underlying pathophysiology, we can identify with this carbon dioxide difference tool, which there the underlying feature is ischemic hypoxia and all. The same vice versa. Even though if it is carbon dioxide, this might be normal, despite the presence of significant hypoperfusion in high cardiac output states of septic shock, where high flow might prevent venous carbon dioxide accumulation. Thus, the ratio between the carbon dioxide and oxygen difference may identify patients at a risk of anaerobic metabolism. Next target is lactate. We know as in SSC bundle, we know lactate we will measure at individual hours. Individual lactate does not have any resuscitation features and any prognostic implications. So we have to do it always with the lactate clearance. Means how much lactate is cleared from the body apart from the resuscitation also. The same means at 0 hours, at 8 hours and 24 hours. No consistent advantages have been found for the lactate based resuscitation over the resuscitation guided by oxygen parameters. Therefore, additional markers of inadequate perfusion should be explored, especially when central venous oxygen values are close to normal. That's why in our study, we correlated the carbon dioxide to oxygen ratio in identify patients at a risk of adverse outcomes in septic shock, and it should correlate with the lactate clearance. The main aim of the study is I will measure ABG and the venous blood sample from the central line. Then I will measure at arterial oxygen difference between arterial and venous blood and carbon dioxide difference between arterial and venous blood at 8 hours and 24 hours and at the baseline. And the same time lactate also at 0 hours, 8 hours and 24 hours. At 8 hours, I made a clearance of more than 10% as a cutoff value. But as at 24 hours, I took 20% at the cutoff value. According, I divided it into two groups. At 8 hours means 8A and 8B. At 24 hours at 24A, 24B. The methodology it is done as a prospective observation study done in 100 patients around in 18 months period. Inclusion criteria is patients with a septic shock, adult patients more than 18 years and who gave consent, and the person with already known case of CKD, CLD and pregnant patients and who gave a negative consent, they are excluded from the study. And we guided these oxygen parameters with already our known formulas like arterial oxygen content, which is like oxygen dissolved in the hemoglobin plus oxygen dissolved in the plasma. The same with the venous oxygen content, which is also the same. Then arterial venous oxygen content difference, the same with the carbon dioxide. Carbon dioxide difference between the venous blood and arterial blood and the ratio between the carbon dioxide and oxygen ratio. The same goes with the 8 hours lactate clearance. At 0 hours minus 8 hours by 0 into 100. At 24 hours is 0 minus 24 by 0 into 100. If it is more than 10%, it is 0 to 8 hours. If it is more than 20% from 0 to 24 hours. Results are carbon dioxide to oxygen ratio showed a p-value less than 0.0001, which is statistically significant. The same time, at the carbon dioxide to oxygen ratio at 8 hours gave a cutoff value of 1.3134, whereas at 24 hours it gave us 1.3729. And the Pearson's correlation between carbon dioxide to oxygen ratio versus lactate clearance. At 8 hours, it is 0.009, whereas at 24 hours, it is 0.001, which both are statistically significant. Discussion is the cutoff value we got 1.31 and 1.37 at 8 and 24 hours, and we found that high carbon dioxide to oxygen ratio was related to the poor lactate clearance at both 8 hours and 24 hours after initiation of the resuscitation. Therefore, in our study, if it is more than 10%, more than 20%, shows the lower mortality, means good. If there is a good lactate clearance, it is lower mortality. If it is less lactate clearance, it is higher mortality. And at 8 hours, there is no difference between survivors and non-survivors. Whereas at 24 hours, there was statistically significant between the survivors and non-survivors. Thus, the carbon dioxide oxygen ratio at 24 hours may have a prognostic implications and have a better predictive value than that of the 8 hours. And overall, the carbon dioxide to oxygen ratio is a close surrogate for lactate clearance, and it is a simpler tool with arterial blood gas sample and venous blood sample, which can be helpful done routinely. Thank you.
So are we asking the questions right now or later on, Shilpi? Hello. Hello.
Sir, later we'll answer the question.
Later on, okay. So we'll call the next speaker, Dr. Ansika Yadav, who will be discussing.
Good evening, I am Dr.
comparison.
Ansika Yadav, resident RNT Medical College, Udaipur, presenting my paper on comparison of maternal outcome of cesarean section and factors affecting it in COVID-positive parturients during first wave and second wave of COVID-19, a single center study. First of all, the introduction. The coronavirus pandemic first started in Wuhan, China, after affecting thousands of population there, and subsequently over a period of few months spread throughout the world. The first case of COVID-19 was reported in India, in Kerala, on January 27, 2020. The second case of COVID-19 started in March 2021, peaked in May 2021, with sporadic cases still going. This is a picture showing the trends and peaks of COVID-19 disease in India, with peaks happening in September 2020 in first wave and May 2021 in second wave. The second wave proved hard hitting to the pregnant women than the first wave because of the physiological changes, the surgical stress related to the cesarean section and deranged coagulation profile, pregnancy being a hypercoagulable state. The coronavirus disease posed a major threat to the lives of these pregnant patients. We conducted this study to look for various factors affecting the outcomes of parturients undergoing cesarean sections who came COVID positive. The aim of the study was to compare the maternal outcome of cesarean sections and factors affecting it in COVID-positive parturients during these waves, and to compare the clinical profile, inflammatory markers, severity of illness, and need of oxygen support in these parturients for these two waves and their effect on their outcome. A retrospective observation study was done during the records of the COVID-positive parturients who underwent cesarean sections during these two waves of COVID pandemic in dedicated COVID care hospital attached to RNT Medical College, Udaipur, Rajasthan, after getting approval from our institutional ethical committee. All RT-PCR COVID-positive parturients who underwent cesarean section, elective plus emergency cases were taken. COVID positivity was established by the nasopharyngeal or oropharyngeal swabs taken from the parturients and sent for RT-PCR SARS-CoV-2 assay. 46 cesarean sections were conducted over a period of 6 months in the first wave, and 87 cesarean sections were conducted over a period of 3 months in the second wave. Clinical profile, severity of illness, blood investigations such as CBC, RFT, LFT, inflammatory markers such as CRP, IL-6, T-dimer, serum ferritin, oxygen requirement, mode of anesthesia, maternal and neonatal outcome were recorded in these patients. The severity of illness was decided according to the guidelines of Ministry of Health and Family Welfare COVID severity categorization. Statistical analysis was done using the chi-square test for categorical data and t-test for the continuous data. P-values less than 0.05 were considered significant. All data was statistically compared between two waves to find out risk factors for maternal mortality. Now, this is a graph which is showing month-wise distribution of cases which came at our center. The data coincides with the national data as shown previously. Now the results and observation. Incidence of maternal and neonatal mortality was statistically significant in second wave as compared to the first wave. 10% maternal mortality, that is 9 out of 87 cases, and 8% neonatal mortality, that is 7 out of 87 cases occurred in second wave. Data such as demographics, such as age, weight, were also compared between two waves. Comorbidities were also compared. They were statistically insignificant. Severity of illness and oxygen support was statistically significant in second wave, with 17 severe cases in second wave versus 1 case in first wave. Out of these 17 cases, 3 cases were on HFNO, 14 were on NIV. Out of these 14, 9 deaths occurred, and in that 9 deaths, six patients were on mechanical ventilation. In the second wave, patients were having more leukocytosis and increased blood urea, which was statistically significant. The mean value of various inflammatory markers were such as CRP, IL-6, serum ferritin, D dimers were also significantly higher in second wave as compared to the first wave. We also compared the intraoperative parameters to see whether our anesthetic management would affect the outcome of these pregnant patients. No statistical significance was found. In a study by Mahajan et al. For pregnancy outcomes and complications during of coronavirus disease 2019, the rate of severe COVID-19 infection, the rates of ICU admissions, case fatality, and maternal mortality was higher during the second wave. In a study done by Jain et al., oxygen requirement and requirement of mechanical ventilation was more in second wave. In a study done by Kapoor M. et al., higher age, oxygen requirement, ventilator requirement, ICU admission, and organ impairment were more prevalent in the admitted COVID-19 cases during the second wave. In the study done by Mahajan et al., highly virulent variant of the virus, that is Beta strain, was suspected to be the cause of increase in severity and mortality in pregnant patients. Also, higher case rates and delays in seeking healthcare were also contributors to increased mortality during the second wave. In conclusion, in the second wave, maternal and neonatal mortality was significantly higher as compared to the first wave. The severity of illness, need of oxygen support, and inflammatory markers were significantly higher than the second wave and found as a risk factors for the adverse maternal outcome. Thank you.
Can we have Dr. Christopher coming in? A slide, please.
Slide तो है नहीं, unmute कर दिया मैंने. Good evening, everyone. Now I would like to call upon our next speaker. Next speaker is Christopher J. V. Lowe. His topic is ivermectin for patients with coronavirus disease, a meta-analysis with trial sequential analysis of randomized controlled trials. Dr. Christopher, please start your talk.
Dr. Geeta, I guess we can move on to the next speaker after him since he has not submitted the talk.
Okay. I would like to welcome next speaker. Next speaker is Anjali Kumari. She'll be speaking on evaluation of the effects of N-acetylcysteine and vitamin C on C-reactive protein and LDH enzymes in abdominal sepsis patients. Dr. Anjali.
Hello and welcome all. My study for the paper presentation is evaluation of the effects of N-acetylcysteine and vitamin C on C-reactive protein and lactic dehydrogenase enzymes in abdominal sepsis patients. This is a randomized placebo-controlled study. It was conducted in Department of Anesthesiology and Critical Care, Jain Medical College, AMU, Aligarh. Introduction. Sepsis is the most common cause of death in ICU worldwide, characterized by a systemic inflammatory response to an infective insult. Rise in various enzymes is due to the oxidative stress during sepsis, and they help in early detection, improving the outcome. CRP is an acute phase protein, daily measurement of which is useful in detection of sepsis. Increase in LDH in severe sepsis reflects the extent of tissue injury. Recently, the biomarkers CRP and LDH have also played a significant role in diagnosing and assessing the severity of COVID-19 disease. To reduce the increase in reactive oxygen species due to oxidative stress, various antioxidants like N-acetylcysteine and vitamin C have been used. N-acetylcysteine can replete intracellular reduced glutathione responsible for scavenging free radicals, whereas vitamin C, being a water-soluble antioxidant, is capable of broadly scavenging reactive oxygen species. In this study, we aim to evaluate the effect of antioxidant agents, N-acetylcysteine and vitamin C, in reducing the level of sepsis markers LDH and CRP in patients with abdominal sepsis. Now, the aims and objectives of the study. The primary aim was comparison between post-operative day 1 and 4 level of markers LDH and CRP in patients receiving placebo, N-acetylcysteine, vitamin C, and N-acetylcysteine and vitamin C given together. The secondary aim was comparison between the different groups to detect which is the most effective antioxidant agent among N-acetylcysteine and vitamin C. Now, the materials and methodology. 60-year-old patients with abdominal sepsis were enrolled after approval from the Institutional Ethics Committee and the Board of Studies of the department. Setting, it was based in ICU, anesthesiology and critical care, Jain Medical College, AMU. The group division was as follows. 60 patients were randomly divided into 4 groups of 15 patients each. Randomization was done using computer-generated random numbers. The groups were as follows. Group A, the placebo group, they received 100 ml of 5% dextrose 8 hourly for 3 days. Group B, the N-acetylcysteine group, received N-acetylcysteine at 70 mg per kg in 100 ml of 5% dextrose 8 hourly for 3 days. The group C, the vitamin C group, received vitamin C at 25 mg per kg in 100 ml of 5% dextrose 8 hourly for 3 days. The group D received both N-acetylcysteine and vitamin C together. Blood samples were collected preoperatively, post-op day 1 before giving the drug, and day 4 of study from each group. Biochemical analysis was done to measure the levels of CRP and LDH. Now, the statistical analysis was performed using Microsoft Excel Statistical Package for Social Sciences, SPSS latest version software. The results were presented in number, percentage, mean, and standard deviation as appropriate. A p-value of less than 0.01 was considered statistically significant. Level of markers on day 4 and day 1 were compared within the groups and between groups using ANOVA test followed by post-hoc Dougie test. Results were as follows. There was a significant decrease, p-value less than 0.001 in the level of markers CRP and LDH on post-operative day 4 in the groups B, C, and D, while no change in the group A. As we can see in this statistical diagram, the level of CRP decreased significantly in the groups B, C, and D on day 4 as compared to the group A. These groups, group B, C, and D, were the group where drug was given. Now, in this graph also, we can see the decrease in the level of LDH. Now, for both the markers, percentage change was more in group D, but not significantly different from B and C. Conclusion. So, we can conclude that antioxidants N-acetylcysteine and vitamin C administered individually and in combination can significantly reduce the oxidative stress following sepsis. The results of this study may be employed in patients suffering from COVID-19 disease also. However, a study may be designed with a larger sample size to evaluate the 28 days mortality outcome. Here are the references on which our study was based. Thank you.
Thank you, Dr. Anjali. Now we will move to the next presentation. Next presentation will be by M. Ravi Krishna. He will be speaking on the 4 DPRR index for mortality prediction in COVID-19 ARDs. Dr. M. Ravi Krishna, please start with your presentation.
Good morning, faculty and my dear friends. My name is Dr. M. Ravi Krishna. I'm a third-year DM resident in the Department of Critical Care Medicine from the Anand Medical College and Hospital, Ludhiana. Today, my topic is 4 DPRR index for assessing mortality in COVID-19 ARDS. Till recently, lung protective ventilation was mainly focused on low plateau pressure, high PEEP modes of high PEEP ventilation. But research over the past 2 decades has shown that rather than plateau pressure and high PEEP, there are other factors which affect the ventilator-induced lung injury, which include driving pressure and mechanical power, which itself can cause ergotrauma to the patient. So recently, research has been focusing on minimizing the mechanical power delivered to the lungs to minimize this form of ventilator-induced lung injury. But mechanical power is affected by various factors which include tidal volume, plateau pressure, airflow rate, respiratory rate, and P. But the weightage of each component of this mechanical power is uncertain. So recently, a trial was conducted by Costa and et al., in which they have evaluated a simple composite variable called as 4D PPR index, which is 4 into driving pressure plus respiratory rate. They have evaluated this as a surrogate for mechanical power for assessing mortality in patients with ARDS. Coming to aims of the study, we aim to evaluate the association of 60-day mortality with using the 4D PPR index for assessing mortality in our subset of patients. We have retrospectively collected data from 35 COVID patients. The data collected includes plateau pressure, driving pressure, respiratory rate, and mortality at 60 days. All the patients were ventilated as per surviving sepsis COVID-19 guidelines. The mechanical power was calculated using 4D PPR, and the values were collected at admission and 24 hours after mechanical ventilation. Coming to results, 37% of the patients had a plateau pressure of 26 to 30, whereas 32% had a plateau pressure of 34 to 38 centimeters, 5% had plateau pressure of 30 to 34, and 38 to 42. Coming to driving pressure distribution, 29% of the patients had a driving pressure of 16 to 19 and 19 to 22. Coming to respiratory rate distribution, most of the patients had a respiratory rate between 20 to 30. Very few patients had respiratory rate less than 20 cycles per minute, and none of the patients had a respiratory rate more than 30 cycles per minute. Coming to mechanical power computed using the 4D PPR, the mechanical power ranged from 82 to 152 in our group of patients. 21% of the patients had mechanical power from 102 to 112. 18% each had a mechanical power of 112 to 122 and 122 to 132. Coming to outcomes, 29% of our patients have succumbed to COVID-19 ARDS, and we were able to discharge 71% of the patients. Coming to the ROC curve distribution, only plateau pressure and respiratory rate showed high sensitivity, whereas 4D PPR showed poor sensitivity. After analyzing the data, we found that driving pressure had a p-value of 0.042 and a plateau pressure had a p-value of 0.03, and they were significantly associated with 60 days mortality. Coming to 4D PPR, it was found to have no significant association with mortality, with p-value being 0.79. Coming to the conclusions of the study, we could derive that driving pressure and plateau pressure were associated with 60-day mortality during controlled mechanical ventilation during COVID-19. Whereas if we have used a simpler model of mechanical power using the earlier set formula of 4D PPR, it was found to be a poor predictor of mortality. And this is in direct contradiction to the earliest published single study by Costa et al., in which they found it was associated with mortality. This could be easily explained by the limitations such as the small number of patients which we have included and the retrospective data collection. It can also be mainly due to the different phenotypes of COVID ARDS, which are not seen in earlier set types of ARDS, and hence the COVID ARDS may not benefit from the same ventilator strategies which we use for other types of ARDS. And we also have other limitations, like only moderate to severe ARDS patients were included in our study. Thank you.
Now I would like to welcome our next speaker. Next speaker is Raman Sharma. He will be presenting COVID-19 mortality in children. Dr. Raman Sharma, please start your talk. Hello, am I audible?
Yes, you are audible. We'll move to the next.
Yes.
Avani Mukund.
Next speaker is Raman Sharma, Dr. Raman Sharma. He will be presenting COVID-19 mortality in children. Dr. Raman Sharma.
Shilpi ji. Shilpi ji.
Ji, Hanji. Dr. Raman Sharma is regretted. We'll move on to the next speaker, please.
So Dr. Vimal Bhardwaj, can you call the next speaker?
Madam, I have no information about the speaker, so I can't speak.
Okay. So I'll call the next speaker. Next speaker is Dr. Avni Mukund Paithankar. Dr. Avni, please start your presentation.
MGM Medical College and Hospital, Aurangabad. I am Dr. Avani Mukund Paithankar, presenting a paper on antibody responses in vaccinees with first and second dose of SARS-CoV-2 viral vector vaccine. By the end of 2020, more than millions have been diagnosed with COVID-19 infection. The complications of COVID-19 had led to more than 230,000 deaths in India and 3.24 million globally. Remarkable efforts have been devoted to the development of vaccine to prevent COVID-19 and to reduce morbidity and mortality among those who are infected. Global efforts to develop safe and effective COVID-19 vaccine through efforts like Operation Warp Speed was made possible. Following are certain observations of a clinical relevance which need attention. How does a person develop COVID-19 infection after a couple of weeks of first or second dose of vaccination despite observing preventive discipline strategies? In vaccinees, we have no proper answer for realizing patients' varied initial symptoms and presentation, whether the symptoms are similar or dissimilar to the earlier scenario. One needs to find out that a single or a second dose of vaccine elicited rapid, delayed, or a poor immune response in seropositive or seronegative participants. Whether the titers are similar or exceeded the titers observed in seronegative and seropositive participants. It is a prospective observational study. Candidates were divided in 3 equal groups. Number of patients enrolled are 63. And serum IgG antibody titers were done with a chemiluminescence method. Data collected and analyzed by SPSS version 24. My inclusion criteria: first group, Group A, individuals with pre-existing infection who received either first or a second dose of COVID-19 vaccine. Group B, individuals with no pre-existing infection who received either first or a second dose of COVID-19 vaccine and developed SARS-CoV-19 RT-PCR positivity within 3 to 6 weeks and 72 hours of onset of symptoms suspected of having COVID-19 infection. Third, participants with no pre-existing disease who are asymptomatic in 3 to 6 weeks post-vaccination are considered healthy and are categorized as a Group C. Exclusion criteria: vaccinees who had COVID-19 developing symptoms with RT-PCR positivity but presenting over 72 hours of onset of symptoms, as antibody titers may be noticed elevated post-infection if the tests are performed beyond 72 hours of onset of symptoms. Asymptomatic RT-PCR positive carriers and symptomatic RT-PCR negative carriers are excluded from the study. Statistical analysis: we have used G-Power software and chi-square and ANOVA test are applied. This is a chart showing a comparative of a clinical features between group A, B and C. Generally, headache and acute febrile illness is a more common post-vaccination irrespective of a group. This is a graph showing antibody titer comparison between group A, B and C. Group A shows high antibody titer as compared to group B and group C. Group A, that is previously infected and then vaccinated, has high titers, that is 23.35 plus or minus 16.77. Group B, which had no previous infection and vaccinated and post-vaccination developed infection, having low titers compared to Group A, that is 8.33 plus or minus 1.78. Group C, which is of healthy individual with RT-PCR negative persons with no previous infection who were vaccinated, titer was found to be 2.28 plus or minus 2.09. It is obvious from the above results that group A had high antibody titers. It could be because of a vaccination which followed previous infection, which did not take place in group B and C. This is a graph. This is a table showing mean antibody titers of group A, B and C. In other studies like NEGM, the antibody titers of vaccinees with pre-existing immunity were 10 to 45 times as high as those vaccinees without pre-existing immunity at the same point of time after first vaccine dose, and also exceeded the median antibody titers measured in participants without pre-existing immunity after the second vaccine dose by more than a factor of 6. Participants with SARS-CoV-2 antibodies at a baseline before the first vaccine injection rapidly develop uniform high titers within days after vaccination. Although the antibody titers of vaccinees without pre-existing immunity increased by a factor of 3 after the second vaccine dose. So, high and low titers of IgG antibody post-vaccination done has a no safety bridge. It is an interlinkage between neutralizing antibodies post-vaccination, antibody titers post-vaccination, and T-cell nasal memory local immunity that decides protection and a safety measures against COVID-19. Conclusion: from a post-vaccination antibody titers, it is evident that antibody titers levels does not correlate with a reinfection, mutant variant, immune response of the patient. Low titers and a reinfection may suggest poor humoral immunity. Also, because of a mutation and a T-cell immunity and a local nasal immunity may be intact or a low, while patient has a high titers and a reinfection suggest mutant variant. Hence, post-vaccination antibody titer should not be undertaken for a screening purpose or as a routine. And these two are the main references. Thank you.
Thank you, Dr. Avni. We'll continue with the next talk. Next talk will be by Dr. Vivek Gautam. He will be presenting a retrospective study of outcome of remdesivir on survival and hospital stay in RT-PCR positive COVID-19 patients. Dr. Vivek, are you there? Okay.
Good evening, everyone. I am Dr. Vivek Gautam, and I'll be presenting my paper on a retrospective study of outcome of remdesivir on survival and hospital stay in RT-PCR positive COVID-19 patients. As we all know, remdesivir is a prodrug of a nucleotide analog that is intracellularly metabolized to an analog of adenosine triphosphate that inhibits viral RNA polymerases. Remdesivir has broad spectrum activity against members of several virus families, including filoviruses, coronaviruses, including SARS-CoV and Middle East Respiratory Syndrome coronaviruses, and has shown prophylactic and therapeutic efficacy in some models of these coronaviruses. In vitro testing has also shown that remdesivir has activity against SARS-CoV-2 infection. Recently, WHO created a headline when they made a statement that remdesivir appeared to have little or no effect on hospitalized COVID-19 patients after they concluded their clinical trial. While some studies did not lay the bar too much in favor of remdesivir, we still carried out our own study, and we started to get a lot of desirable outcomes in various sects of patients, and COVID-19 still being in its prime phase, we did every bit of investigation and evaluation to check its spread. Our study was carried out over a period of 3 months in a total number of 80 confirmed COVID-19 cases of various age groups, with almost all of Indian origin. Ultimately, their survival and discharge from the hospital on a good saturation, on room air, or even on home low flow oxygen support was a positive indicator for us to continue the use of remdesivir with little to acceptable side effects. We provided remdesivir on a compassionate use basis to patients hospitalized with COVID-19, the illness caused by infection with SARS-CoV-2. Patients were those with confirmed SARS-CoV-2 infection who had an oxygen saturation of 95% or less while they were breathing ambient air or who were receiving oxygen support, and even those on invasive ventilation. An HRCT thorax was done on most of these patients to check their CT severity scores and were grouped accordingly. It's worth mentioning that the initiation of remdesivir course from the day of onset of first symptom played a vital role in the outcome as we got patients who presented early as well as late after they had their first symptoms. Patients were categorized according to their saturation on arrival, mostly varying between 60 to 95% at room air. The course was mostly a 5-day course consisting of 200 milligram IV dose on day 1, followed by 100 milligram daily for the remaining 4 days of treatment. In some cases, we extended the course by 10 to 12 days. The first table shows that out of the patients grouped according to their SpO2 on arrival, it was observed that the ones in the 91 to 95% range showed the most significant improvement with remdesivir with a survival percentage of 94.7%, followed by 91.9% in the ones in the 81 to 90% SpO2 range. The next table shows that out of the patients grouped according to their CT severity score on the basis of HRCT thorax, it was observed that the ones with the score of less than or equal to 8 had a survival of 100%, followed by 96.3% in patients with a score of 9 to 15, and lastly 88.9% in patients with a CT severity score in the range of 16 to 25. For the final table, we categorize the patients according to the start of remdesivir from the day of onset of first symptoms. Here it was observed that the patients who were given remdesivir within 5 or less days from their onset of first symptoms had a survival rate of 90.6%, followed by 87.2% in patients with start of remdesivir within 6 to 10 days. Lastly, those who were given remdesivir on or after 11 days had the worst survival rate of 77.7%. Hence, this entire study led us to some conclusion that remdesivir yielded the most positive results in the following scenarios. If it was started earliest from the onset of symptoms, irrespective of when the patient took RT-PCR or antigen test. A lower CT severity score yielded best results with remdesivir, and remdesivir helped weaning patients off oxygen or helped decrease their supplemental oxygen requirements when they were in the range of 81 to 95% on arrival. So some might debate if remdesivir halts or lowers the progression of SARS-CoV-2 infection or not, but our study clearly showed that the overall remdesivir surely helped in reducing the stay of patients in the hospital and helped us to wean them off supplemental oxygen faster than other medicines. So in this desperate time when we have started to rush ourselves to vaccinate with various COVID-19 vaccines, which are still under trial or have received little to much approval, this little research molecule still goes a long way to help a symptomatic patient with proven SARS-CoV-2 infection with a mild to moderate CT severity score and SpO2 equal to or more than 81%, provided we are able to start it as early as possible from the onset of symptoms. Thank you.
Thank you, Dr. Vivek. Now we'll start with the next presentation. Next presentation will be by Dr. Bhuvna Ahuja. She'll be presenting a comparative study of the protection rate and recovery characteristics among recipients of the Covishield and Covaxin vaccine for SARS-CoV-2.
Good evening, respected seniors and dear friends. Today I'll be presenting a comparative study of the protection rate and recovery characteristics between Covishield and Covaxin recipients following vaccination for SARS-CoV-2. SARS-CoV-2 pandemic brought world to a standstill. To control its spread, vaccine appeared to be the best possible way. The availability of a safe and effective vaccine for SARS-CoV-2 is well recognized to help break the chain. Thus, it became vital to evaluate the effectiveness of vaccines which were rolled out at fastest possible time. Therefore, we formulated the following survey of Covaxin and Covishield. The prospective questionnaire-based survey was undertaken amongst the healthcare workers vaccinated with either Covishield or Covaxin against SARS-CoV-2 infection to compare the protection rates and recovery characteristics of the two vaccines. The questionnaire consisted of 15 questions were independently designed by the two investigators and moderated by the third. It was thereafter prospectively validated in their institution in 10 volunteers. Thereafter, the list of eligible healthcare workers for vaccination was procured from the hospital database by the investigators. The healthcare workers who had been vaccinated were invited to participate in the survey on voluntary basis via email or phone numbers via social media. The questionnaire contained information about the type and doses of vaccine received, any occurrence of SARS-CoV-2 infection after vaccination, and their time of onset, and in such cases, their clinical features. Any need for hospitalization, duration, and clinical course of the illness was also included. The occurrence of vaccine-associated side effects was also noted. The responses were obtained in the Google chart and then entered in the software for analysis using SPSS version 24. A total of 124 out of 670 patients, that is about 18.5%, developed SARS-CoV-2 after one or both doses of the vaccine. The demographic characteristics were found to be similar in both the groups, that is Covishield and Covaxin. One important finding which was found was about post-vaccination infection. As you can see in the table, that more recipients developed COVID after the first dose of Covishield, with p-value being 0.04 than after Covaxin, although there was no difference between them after both the doses. As far as comparison of post-vaccination severe COVID infection was concerned, there was no difference in the incidence of severe infection post-vaccination with either of the vaccines, p-value being not significant statistically. Comparison of duration of recovery after post-vaccination also showed no significant difference, p-value being 0.53 only. So hence we conclude that a study found greater SARS-CoV-2 infection following vaccination with the first dose of Covishield than Covaxin without finding any difference in their severity, clinical course and recovery characteristics or in the vaccine associated side effects. Thank you.
Thank you, Dr. Bhuvna. Now the last speaker of the day. Last speaker is Dr. Vaibhav Chawla. He will be presenting modified prone position for awake self-prone ventilation in COVID-19 pneumonia, a randomized controlled trial. Dr. Vaibhav Chawla.
This is Dr. Vaibhav Chawla. I, along with 5 of my colleagues, did a randomized controlled trial on the topic modified prone position for awake self-prone ventilation in COVID-19 pneumonia. Self-awake prone ventilation has changed the management of hypoxic respiratory failure in the last 2 years. It has been endorsed by ICMR as one of the most effective managements for moderate to severe COVID pneumonia. But as we know, everything has its own set of challenges. Multiple pillows are required in an already crumbling setup, and it requires 2 to 3 healthcare workers for assisting, which is problematic in a low resource setup. Additive ventilation like NIV and HFNC are difficult to apply. Patients in fully prone position often feel uncomfortable and anxious, followed by increase in cardiorespiratory work, leading to further worsening. So we planned a study to analyze modified prone ventilation as a viable method for awake prone ventilation and evaluate its effect on patients' comfort. This is standard awake Ministry of Health and Family Welfare approved prone ventilation. The face of the patient is facing towards the bed. We need the day. This is Dr. Vaibhav Chawla. I, along with 5 of my colleagues, did a randomized controlled the day. This is Dr. Vaibhav Chawla. I, along with 5 of my colleagues, did a randomized control trial on the topic modified prone position for awake self-prone ventilation in COVID-19 pneumonia. Self-awake prone ventilation has changed the
You can only speak.
Dr. Vaibhav, do you have the presentation ready with you? If we give you the rights, can you display it right now and share your screen?
Yeah, just a second. This is Dr. Vaibhav Chawla. I, along with 5 of my colleagues, did a randomized control trial on the topic modified prone position for awake self-prone ventilation in COVID-19 pneumonia. Self-awake prone ventilation has changed the management of hypoxic respiratory failure in the last 2 years. It has been endorsed by ICMR as one of the most effective managements for moderate to severe COVID pneumonia. But as we know, everything has its own set of challenges. Multiple pillows are required in an already crumbling setup, and it requires 2 to 3 healthcare workers for a system, which is problematic in a low resource setup. Additive ventilation like NIV and HFNC are difficult to apply. Patients in fully prone position often feel uncomfortable and anxious, followed by increase in cardiorespiratory work, leading to further worsening. We planned a study to analyze modified prone ventilation as a viable method for awake prone ventilation and evaluate its effect on patients' comfort. This is standard awake Ministry of Health and Family Welfare approved prone ventilation. The face of the patient is facing towards the bed. We need at least 3 pillows to carry it out. You can see it's very difficult to apply the NIV or HFNC to this patient. So we changed it a little. This is what we call modified prone ventilation, in which the patient is semi-prone and it's in the swimmer's position. It's more comfortable. It requires 1 pillow, and the patient can easily attach the NIV or HFNC to this. Now, we included the patients who were COVID-19 positive and required 5 or more liters of oxygen to maintain a saturation of 92% or more. We excluded all the patients who had comorbidities like hypertension, diabetes, interstitial lung disease, COPD, asthma, and malignancy. We also excluded all the patients who had previous history of cardiac illness. So we conducted a pilot study of 20 patients in a tertiary care private hospital in northern India in March 2021 to check if the modified prone position was a viable alternative to the standard awake prone ventilation. After the pilot study was successful and it was approved by the Institutional Ethical Committee, we conducted a randomized control trial, which we will be discussing now. From 1st April 2021 to 31st May 2021, that is when the second wave of pandemic hit India, we conducted a study in which 80 persons were enrolled and they were randomized into 2 groups. The first one being standard one, and the other group, it was called modified prone position group. So we evaluated various physiological parameters and the comfort of the patient by the modified Lester comfort scale. Both the groups were evenly matched and received medications according to the standard hospital protocol. So this is what I was talking about, the modified Lester comfort scale. So lesser the score, more the comfort, more the score, more the discomfort to the patient during the test. So we are comparing both of the positions here, and you can see MGCS score is much more in awake prone ventilation. And as I mentioned, lesser the score, more the comfort. So modified prone position appears to be a better alternative. In the next one, we are comparing the prone tolerated duration. That is how long the patient can tolerate the respective position, and the modified prone position is the clear winner. Patients appear to tolerate it better for a longer period of time. And the other parameters as well, you can see that FiO2 requirement baseline SpO2 with 5 liters of oxygen, and the biomarkers are almost the same on both sides. The additional thing I want to mention here is the respiratory escalation. More patients went on for intubation in the awake prone ventilation as compared to the modified prone position, in which just one patient went on for intubation. So it's a good sign. Now, coming on to the results, we're going to compare both of them. The MOHFW approved prone ventilation, it was tolerated for a lesser time, as I mentioned, and it didn't tolerate the HFNC and NIV well, leading to more intubations. The patients were much less comfortable, which was depicted by the high MGCS score, and the anxiety, back pain, and shoulder pain were more common in this group. It also required 2 to 3 healthcare workers for assistance. Whereas in the modified prone position, it was possible for the patient to carry out himself, or one healthcare worker could assist it to make it easy. Now, the prone positioning has proved to be of immense importance for better outcome of COVID patients when most of the drugs were not helping. There was no significant difference in the length of stay, additional medications used, or mortality between the groups, but there was a major impact on respiratory escalation to intubations and tolerating the additive ventilations for a longer period of time. Additionally, modified prone positioning can be easily carried out in poor resource conditions during patient transport and even at home when there is a scarcity of beds in the hospital for better outcomes. But the study had its limitations, like less number of patients got enrolled in the study because most of the patients had comorbidities, which we had to exclude, unfortunately. So modified prone position appears to be a viable alternative to standard awake prone ventilation, and it is more comfortable as better tolerated.
Thank you all the participants. I would like to ask if anyone has any questions for the participants.
The chairpersons can put across the questions if they have any to any of the oral presenters. If there are no questions, we can conclude the session, Dr. Ankita.
I thank all the esteemed chairpersons and I congratulate all the participants for their paper presentation. With this, we thank you all for contributing to the vibrancy of this conference. We look forward to seeing you tomorrow. Thank you and have a great day.